India, with increase in sedentary lifestyle and consumption of unhealthy fats, there is a high rise in cases of diabetes. In India, at present, almost 77 million people above the age of 18 suffer from diabetes. In the past, only treatment for diabetes was strict diet control, but with development in medicine, diabetes can be controlled to a larger extent. I would like to call upon the stage Dr. Vagmare sir, Head of the Department of Pharmacology, to enlighten us on recent advances in the management of diabetes.
First, I would like to invite our chairpersons, Dr. Gajanan Jatti sir and Dr. Taure sir, to increase the grace of the chair. Now, I would like to hand over my mic to Dr. Chandrakant Vagmare sir so that he could guide us on the topic recent advances in the management of diabetes mellitus.
Thank you. Respected Dean sir, my esteemed colleagues and all my dear students, a very good morning to you all. Today I am here to speak on the topic recent advances in the management of diabetes mellitus. Diabetes mellitus, as you all of know, it is a disease with a very high prevalence in India, thanks to the unhealthy lifestyle, sedentary lifestyle adopted by our populations. Overall physical activity has decreased, and even the dietary habits of the people have changed at large. And together, this has led to an epidemic of diabetes mellitus, type 2 diabetes mellitus in India. And we are on the verge of becoming diabetic capital of the world. So, I thought it prudent to speak on this topic with regard to the recent advances in the management of diabetes mellitus. Now, in the recent years, even the pathophysiology of diabetes mellitus has changed. What is that? Earlier it was thought that obesity, sedentary lifestyle, genetic factors are responsible for the causation of diabetes mellitus. But the recent detailed studies in the UK have led to the evidence that when a person is obese, the adipose tissue around the abdomen, abdominal fat, it releases certain cytokines, certain chemical substances, and these substances are responsible for the insulin resistance. That was a very pioneering study done in the UK, and this study led to the development of this hypothesis that diabetes, type 2 diabetes mellitus develops because of the cytokines released by the adipose tissues around the abdomen. So visceral obesity is very important risk factor, and this led to the suggestions that increased physical activity in the form of regular aerobic exercise or overall increase in the physical activity would be able to control the diabetes, and not only control the diabetes but also reverse the diabetes in some cases. So now the objective of the treatment is to reverse the diabetes mellitus. So according to the latest evidence, if a person has diabetes mellitus that has been diagnosed for less than 5 years, diabetes of less than 5 years can be reversible with the aggressive lifestyle changes and dietary as well as lifestyle changes, including increase in the physical activity and regular aerobic exercise. So this is the these are some new addition to the pathophysiology of diabetes mellitus that was earlier not known, thanks to the very important clinical trials conducted in the UK. So, in the context of these changes in the pathophysiology, today I would like to enlighten you on the recent development of drugs in the management of diabetes mellitus that have made diabetes, the treatment of diabetes mellitus very safe, very effective, and even very cost effective for our patients. So, just to define diabetes mellitus, it is an endocrine disease characterized by hyperglycemia, and this hyperglycemia is because of either defects in the insulin production or in the defects in the insulin action, or both, leading to the total derangement of protein, carbohydrate and fat metabolism. That is the universal definition of diabetes mellitus. And there are 4 types of diabetes mellitus. Type 1 diabetes mellitus, which is an autoimmune disorder in which the antibodies are produced against the beta cells of the pancreas, and these patients have very low levels or total absence of insulin, and this is a very severe form of diabetes mellitus. Type 2 diabetes, again, it is largely owing to the lifestyle, the adverse lifestyle, obesity, genetic factors, lack of physical activity, lack of exercise. These are the factors that lead to the type 2 diabetes mellitus. Then there is gestational diabetes mellitus, that is seen during pregnancy. When we screen the pregnant women, we find that some of them have hyperglycemia, and this hyperglycemia may be either the diagnosis of type 2 diabetes mellitus that was not diagnosed earlier, or it could be the beginning of gestational diabetes mellitus. In most cases, this reverses after the delivery of the baby, but these women are more prone to the development of type 2 diabetes mellitus. And in case the patient's pancreas has been surgically removed for some reason, then these people also become the patients of type 1 diabetes mellitus because the pancreas has been removed. Diabetes mellitus, like hypertension, is a silent killer. It can cause a number of complications, microvascular complications or macrovascular complications. So, the macrovascular complications include the development of cerebrovascular disease, development of coronary artery disease, and the development of peripheral vascular disease. Whereas the microvascular complications include diabetic retinopathy, also called diabetic kidney disease, diabetic neuropathy, or diabetic nephropathy. So these are the microvascular complications of diabetes mellitus, and there is a huge burden of these cases in our country because of the improper control of diabetes mellitus. Most of the patients, they are not aware of these complications. So largely the diabetes is improperly, not totally properly controlled, leading to the complications. Just skip. Okay, regarding the diagnosis of diabetes mellitus, it is based on the measurement of plasma blood sugar levels. Now the classification is the pre-diabetic normal blood sugar level. Fasting, if it is less than 100 milligrams per deciliter, it is normal. 100 to 125, it is pre-diabetes, and more than 126 or more, it is diabetes mellitus. Then another test, oral glucose tolerance test. If the blood sugar level is between up to 140 milligrams per deciliter 2 hours after the meal, then it is normal. BSL between 140 to 199, it is pre-diabetes, and above 200, it is diabetes mellitus. There is one more parameter that has been added recently, it is V.M.G.M.C. Up to 5.6, it is normal. 5.7 to 6.5, it is pre-diabetes, and beyond 6.5, it is diabetes. Okay. Now coming to the drug treatment of diabetes mellitus. So there is a very interesting era that started with the Banting and Best, the two medical students who, out of their experiments on the dogs, led to the discovery of insulin as a treatment for diabetes mellitus. कोणाला माहित आहे का experiment by Banting and Best? They removed the pancreas of a dog. So the dog became diabetic. And then they assumed that the pancreas has something, the absence of which is leading to the diabetes mellitus. So they took the extract of pancreas from the other dogs and they treated this dog with this extract. And the dog improved. The dog's condition improved. So this historic experiment led to the discovery of insulin. So when they studied the extract in details, they found that the substance is insulin. And then this insulin was then given to the very first patient, a small boy who was about to die because of the diabetic ketoacidosis. This boy was given the extract of insulin, animal-derived insulin, and the boy survived. So there was the revolution at that point of time. And since then, there has been an era of development of newer and newer drugs for the management of diabetes mellitus. So we have two options. One is insulin, which is used for the treatment of type 1 diabetes mellitus. Also for the patients with type 2 diabetes mellitus who are not controlled adequately with the oral antidiabetic drugs. And the oral antidiabetic drugs that are mainly used for the treatment of type 2 diabetes, and both in terms of insulins and the oral antidiabetic drugs, there has been development of newer and newer drugs that have made the therapy very safe and cost effective for the patients. So I will go through this classification of oral antidiabetic drugs. These are the conventional drugs. Insulin secretagogues are the drugs which of insulin from the beta cells of pancreas. So sulfonylureas like glimepiride, gliclazide, glibenclamide, these are commonly used even today also. So these drugs, they act by increasing the release of insulin from the pancreatic beta cells. Then there is another congener of this class, meglitinides, repaglinide, nataglinide. They have similar action, but the only difference between the sulfonylureas and these drugs is that they have the repaglinide, nataglinide, they have got very quick onset of action as compared to the sulfonylureas. So repaglinide, nataglinide are used in patients. These are newer drugs. Repaglinide, nataglinide, these are the newer congeners which can be used in the patients who are allergic to sulfonylureas. Sulfonylureas, most of the drugs contain sulfhydryl group and it is liable to cause ADRs. So in those patients we can replace the sulfonylureas with the repaglinide or nataglinide. Then among the bigonides, metformin is a very established drug. It is the mainstay of treatment of diabetes mellitus. Almost all the patients receive metformin unless contraindicated. The next is thiazolidinediones. These hate this. Now I would like to mention about these drugs. Thiazolidinediones, they were launched a decade ago, and the examples are pioglitazone, siglitazone, rosiglitazone, and they become very popular with the physicians because they drastically reduced insulin resistance and they were a very good adjunct to the sulfonylureas, and they become very hot favorites of the physicians. Almost everyone started prescribing these thiazolidinediones. But then after a few years of use, we came to know about the severe range of adverse effects with the thiazolidinediones. So these serious adverse drug reactions were revealed after a few years of therapy. And what are these ADRs? Thiazolidinediones, they tend to cause edema and congestive heart failure. They increase the risk of bladder carcinoma. They cause osteoporosis and fractures in women. So these ADRs were revealed, and now, as of now, most of the drugs from this class have been withdrawn. Only few are there, and even the physicians are reluctant to use these drugs in the patients. Then alpha glucosidase inhibitors was a newer addition to the therapy. So it was thought that we can decrease the absorption of glucose from the GIT and thereby we can control the blood sugar levels. And so there was development of drugs called alpha glucosidase inhibitors, and these drugs they used to block the enzyme alpha glucosidase. This alpha glucosidase enzyme is a very key enzyme that is involved in the absorption of the glucose from the GIT. It breaks down complex sugars to the simpler sugars, and which are then absorbed. So atarbose, voglibose are the examples. They are even used today as adjunct to the sulfonylureas and other drugs, and they are quite safe drugs, and they can control the postprandial hyperglycemia. And then next, these are the newer drugs. Thereafter, what follows is a list of newer additions to the treatment of diabetes mellitus, starting with the DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. So this is again a very interesting class of drugs, again very widely used nowadays in the management of type 2 diabetes mellitus. The examples are sitagliptin, linagliptin, vildagliptin, and others. These are called gliptins. So their discovery was based on the physiological substance. Whenever we take carbohydrate diet, our GIT mucosa releases one peptide called GLP-1, glucagon-like peptide 1, GLP-1. This GLP-1 acts on the pancreatic beta cells, and it causes increased release of insulin and also decreases the release of glucagon. So this is a very interesting action with regard to the diabetes mellitus. And this GLP-1 is normally metabolized or degraded by the enzyme dipeptidyl peptidase subtype 4. So there was use of drugs like sitagliptin, vildagliptin, and others, which inhibit this particular enzyme, and thereby they increase the duration of action of the physiological GLP-1, which then goes on to increase the release of insulin and suppress the levels of glucagon. And these are again very widely used in today in the management of diabetes mellitus. The only concern about these drugs is that some studies have shown that there has been an increased incidence of pancreatitis with the use of these drugs. And the basis is that this GLP-1 has action on the beta cells, and there might be excessive stimulation of the beta cells leading to the pancreatic beta cells of pancreas, and causes release of insulin and suppresses the release of glucagon. Now, its action is very transient. It's a physiological substance. Its action lasts for very short duration. It's a very transient action. So there was, based on the structure of this physiological GLP-1, there was development of synthetic analogs of GLP-1 like exenatide, liraglutide, semaglutide. These are the newer drugs from this class. And these synthetic analogs, when given to the patients of type 2 diabetes mellitus, they will act like a physiological of the pancreas. One more advantage of GLP-1 analogs is that the use of GLP-1 analogs is associated with weight loss. Weight loss is an advantage with these GLP-1 analogs. So most of the drugs, they are given by the injectable routes, and very recently the drug semaglutide has become available in the market, and it can be given by oral route. It is a synthetic GLP-1 analog that can be given by oral route. So this is again a new development that will be very convenient for the patient to use the GLP-1 analogs. And lastly, this SGLT2 inhibitors, sodium glucose transporter 2 inhibitors. So normally, I will tell the background of these drugs. Whatever glucose is that comes in the urine during the process of urine formation, 100% is reabsorbed from the proximal tubule. The cells lining the PCT or the proximal tubule, they completely absorb glucose into the circulation, so that nothing enters the urine. So you won't find any traces of glucose in the normal person who doesn't have diabetes mellitus. And this absorption of glucose from the PCT into the interstitium is enabled by this particular enzyme, sodium glucose transporter 2. So this became a target. This was the target in the development of this SGLT2 inhibitors. The examples of these SGLT2 inhibitors are dapagliflozin, canagliflozin, empagliflozin, and these are again very widely used nowadays because they have got a number of benefits that I will tell you. So these SGLT2 inhibitors like dapagliflozin, empagliflozin, canagliflozin, when given, they block this sodium glucose transporter 2 in the proximal tubule of the nephron. When this is blocked, whatever glucose that enters the urine, that is not reabsorbed. So urine will continue to pass lots of glucose. So these drugs act by causing glycosuria. They cause loss of glucose in the urine. This is an entirely different mode of action as far as the diabetes is concerned. And these SGLT2 inhibitors, when they have been used in the patients, they are found to have so many advantages. Number one, patients who are taking SGLT2 inhibitors, their blood pressure is lowered. So they decrease the blood pressure. So if the patient of diabetes has hypertension, the patient's blood pressure is also lowered along with the control of diabetes mellitus. So how they control the diabetes mellitus? They simply cause loss of glucose in the urine. And they also cause lowering of blood pressure, so the blood requirement for the blood pressure medications is also decreased. Second advantage is that SGLT2 inhibitors, they cause weight loss. They decrease the weight because obesity is again a risk factor for diabetes mellitus. So the obese patients are benefited immensely with the use of SGLT2 inhibitors because they cause weight loss. And thirdly, they also protect against congestive heart failure. Patients who have hypertension or pre-existing heart disease, these patients will be benefited immensely because the risk of heart failure in these patients is immensely decreased. And now the cardiologists are using them as a drugs for the treatment of congestive heart failure. They are also said to decrease the risk of cancers. So these are they control blood sugar level, they control the diabetes very well, they lower the blood pressure, therefore they can be antihypertensive drugs, they decrease the risk of congestive heart failure, they decrease the weight, and that is again a big plus for the patients with diabetes mellitus who are obese. The only disadvantage with these drugs is that the patient will continue to excrete glucose in the urine, and therefore the only instruction that has to be given to your patients is have plenty of water and maintain proper genital hygiene. Otherwise, there is an increased risk of urinary tract infections because of presence of lots of glucose in the urine. This is the only major area, but that can be countered by asking the patient to drink plenty of water and maintaining proper genital hygiene. So today is an era of SGLT2 inhibitors. Many, even the cardiologists and others are prescribing these SGLT2 inhibitors for the management of even cardiac elements, heart failure. It protects the patients against heart failure. So that was the update about the recent advances in the management of diabetes mellitus. So GLP-1 analogs, then this gliptins, DPP-4 inhibitors, and the SGLT2 inhibitors are the recent addition to the therapy of diabetes mellitus. And very few days back, there has been a release of data by the Lancet regarding the diabetes, prevalence of diabetes in the Indian scenario. So it is estimated that there are around more than 10 million patients of diabetes mellitus today, and more than 13 million cases of pre-diabetes. Now, pre-diabetes is a condition that is precursor of diabetes mellitus. If you can detect this pre-diabetes early, we can definitely prevent the diabetes mellitus by adopting positive lifestyle measures, and by the use of drugs like metformin, we can prevent the diabetes mellitus. And now the focus has been on the diabetes reversal. The people who have recently diagnosed diabetes mellitus, they are the candidates for this therapy. That is diabetes reversal. It is said that the accumulation of adipose tissues in the visceral organs, that is the reason for diabetes mellitus type 2. That causes the insulin resistance. So if a person goes on doing regular aerobic exercise at least 30 minutes a day, on at least 5 days a week, 30 minutes a day, on at least 5 days a week, that will offer protection against the diabetes mellitus. Then overall increase in the physical activity. It is said that continuous sitting for more than 4 to 6 hours, it is again a risk factor for diabetes mellitus. So those who are sitting continuously in their chairs, they have to get up from their chairs after every 1 hour and at least stand up for 5 minutes, 2 to 3 minutes or 5 minutes. Or whenever possible, they can have a leisure walk in between. This will break the cycle of this sedentary lifestyle. This is again a very key measure that can be taken to control or to prevent the diabetes mellitus. And of course, the dietary measures, they have to be properly followed by the patients of diabetes mellitus. And dietary measures plus regular aerobic exercise, decreased sedentary lifestyle, these together will be very, very useful in controlling the diabetes mellitus, and in some cases even we can reverse the diabetes mellitus. Type 2 diabetes mellitus can be reversed in some cases, provided they aggressively follow the lifestyle changes. So that was the update on the recent advances in the management of diabetes mellitus. So that is all I have to say for this topic. If someone has any questions, they are welcome. कोणाला काही प्रश्न असेल तर विचारू शकता. Yes.
Sir, as you said that in the SGLT2 inhibitors, there is an excretion of the glucose from the urine. So, sir, doesn't it cause any kind of hypovolemic shock or loss of water or dehydration in the body?
No. What we advise to our patients who are taking SGLT2 inhibitors is that they have to firstly take plenty of water. It is a must. It is mandatory to advise them. They must take plenty of fluids, and the risks of UTIs, frequent UTIs are common in these patients. So they have to maintain proper general hygiene. And because of loss of sodium along with glucose, there is also fall in the blood pressure. So if there are many of the patients with diabetes, they also have coexisting hypertension. So their anti-hypertensive medication requirements are reduced with the use of SGLT2 inhibitors, because this drug is also capable of lowering the blood pressure.
Sir, is there any update on oral insulin, sir? Because I read an article where we are trying to develop oral insulin, which is this gastro-resistance insulin. So is there any update regarding this, sir?
There have been, yes, it's a good question, but there have been many attempts in developing oral insulin, but the feasibility factor is there. It doesn't allow the development of molecules. There have been attempts at encapsulating the insulin molecules with some polymers and all that, but the clinical trials, the studies have not been successful. And there, interestingly, people then thought of using nasal mucosa as a route of administration of insulin, because insulin, if it's placed in the nasal mucosa, it is readily absorbed, but it has to be mixed with detergents. So that also underwent clinical trials. But the use of detergent chronically in the nasal mucosa, that led to the atrophic changes in the nasal mucosa and other complications. So again, that was also abandoned. But now, with regard to insulin, we have excellent newer analogs of insulin available in the market. For example, insulin Lispro, insulin Aspart. These are ultra short-acting insulins, and these can be taken with the help of a pen-sized injector, portable pen injector, which is that delivers automatic required insulin levels, insulin amounts to the patient. Insulin Lispro, insulin Aspart, and insulin Glargine, which is a longer-acting version, that is also available. And one more problem with insulin was that in the patients with diabetes, type 1 diabetes mellitus, when the insulin injections were given, initially there was crest. The plasma levels of insulin used to rise drastically in the initial phase, leading to hypoglycemia, episodes of hypoglycemia. And thereafter, the levels used to fall below the therapeutic levels. So that led to the, again, hyperglycemia. So there were episodes of hypoglycemia and hyperglycemia. There was no adequate control with the conventional insulins. But now we have what are called the peakless insulins. Insulin Detemir, Degludec, these are called peakless insulin. That is, once you administer them, their plasma levels remain constant within the therapeutic range. They don't have crests or troughs. So there is neither risk of hypoglycemia nor hyperglycemia. So there is a very good control of the blood sugar levels with these peakless insulins. Again, this is a newer update. I actually forgot to update on this newer insulins as well.
So I would like to thank Dr. Chandrakant Wagmare sir for giving us so deep information on diabetes. Sir almost began from the history, then entered into the molecular level, then its mechanism, then sir took a deep dive into the treatment, and finally the most important, that is the preventive measures of the diabetes mellitus. Now I would like our chairpersons, Dr. Jatti sir and Dr. Taure sir, to felicitate Dr. Chandrakant Wagmare sir. Sir, give a big round of applause. Thank you, sir. Now, we are going to commence with our second conference, that is going to be conducted by Dr. Darke sir, Professor and Head of Department of Medicine. The topic is basically travel medicine. Imagine you are traveling on a road and suddenly one of your close ones, or might be you, get a severe chest pain. At that time, the fear which arises among you or your close ones is the most dangerous fear, because as we know that life is the greatest gift of the nature. So the fear of losing the life is the greatest fear. So there comes the knowledge of travel medicine, which can help us to get out of the situation. So I would like to invite upon the dais Dr. Dadke sir, so that he could give us some information regarding the travel medicine and enlighten our knowledge.
Good afternoon, everybody. Respected Dean sir, V.M.G.M.C sir, my teachers, Wagmare sir, Chincholkar sir, Taure sir, and my dear colleagues, this madam, all the Dadke madam, all these residents and students, my friends. Yesterday I got called to your lecture on travel medicine. In fact, it was a very new topic for me. We are teaching all this academic medicine, but travel medicine is a new term. But I found some literature, Google, and there is a chapter that travel medicine is available. So a lot of material is there. So I would like to give some basic information, short information, which is important for us, those who are going abroad or in India also in a high altitude, that is beneficial for you. Next please. This is the travel. We can travel by air, by train, by bus, by auto, by anything. We can travel different ways. So what problem we face by traveling we'll discuss in short. Next please. So this is travel. We are always be enthusiastic by going to abroad or other places where always our adrenaline level is increased. We are very much enthusiastic. So this is the picture that we are ready to go abroad or anything. Next please. थोड़ा सा क्लियर होना नहीं है, असच रहना ठीक है. ट्रैवल मेडिसिन, इट इज अ ब्रांच ऑफ मेडिसिन. Travel medicine, it is a multidisciplinary branch. It is an interdisciplinary specially concerned with prevention of the infections. Then personal safety is very important. Then avoidance of environmental problems, management of health problem during traveling. These are the basic goals when we are travel from this place to other places. That is called emporiatrics, concerned with safety, management, prevention of the health of the traveler. The speciality of the travel medicine is a dynamic and vast in its medical knowledge requirements, as it focuses on the prevention and management of health issues related to global travel. Areas of experience include vaccination, epidemiology. We know that a lot of times with the pilgrims nowadays, last month we have vaccinated a lot of people going to Hajj and meningococcal meningitis. Those who are going to USA, yellow fever vaccine. Lot of vaccines are encouraged, otherwise they are allowed to enter their countries. The specific travel medicine, pre-travel management. Pre-travel management is very important. When you are going to other countries or any state or anywhere, you have to be careful about what precaution you will take before traveling. Then the pre-travel management, travel-related illnesses, and post-travel management. This increases globalization of travel. We go outside, we go high altitudes, we go hilly areas, and come back after 8 to 10 days. We feel some tired. We feel some very much sick, ill. That is also important concern for us. Not only travel, but post-travel management is also important. Next please. What is our main focus while traveling? The travel medicine includes pre-travel consultation and evaluation, continuous travel and post-travel, just I discussed. Then information is provided by the WHO that addresses health issues for travelers for each country, as well as the specific health issues in travel itself. Just I told that the specific countries has got specific precautions. Like India is endemic for malaria. If you want to go to USA, you have to start chloroquine 2 weeks prior year, 2 tablets per week, chloroquine for 2 weeks. Then after entering in USA, you have to take 4 weeks, 2 tablets chloroquine 4 weeks. That is India. They are very much concerned about their health. Next please. The directions. The field of travel medicine encompasses a wide variety of disciplines, include epidemiology, infectious diseases, public health issues, high altitudes, travel issues. All these points we have to discuss, and these are the directions which are very important by traveling in any person. Next please. Special activities include that cruise ship travel. If you are traveling to the ship, the problems are different. Diving, mass gatherings, example just I told you, mass gathering is there. You have to take the health of the people, concerned about the health. And wildness, remote region travels. Remote, you can go to hill areas and all these remote areas also, different problems are there. Travel medicine has subsequently become a dynamic, multidisciplinary specialty that encompasses aspect of infectious diseases. Infectious diseases more common while we traveling. Like it comes through we are taking some breakfast, we are drinking water, we are eating biscuits. Lot of things will be there. the tropical medicine, wild medicine and appropriate immunization, just discuss. Because if we are traveling, you have read some books or anywhere news that somebody is traveling with you, somebody has given biscuits and he became unconscious. Then he got to admit. Because that is one of the issue that may happen in during traveling. Be cautious about this. Travel medicine can primarily divide into 4 main topics. Which are the 4 main topics? Prevention, wellness of medicine, access and assistance. These are the 4 aspects you have to be careful while traveling. Key areas to consider are vaccination and 6 I's. What is first is vaccination. Just I told malaria vaccine, typhoid vaccine, yellow fever vaccine and routine diphtheria and all this you have to very careful. You know that after you complete your PG and UG, there is one format by going Western countries. You have to fill yellow. I given 2-3 my friends also yellow vaccine, vaccinated, diphtheria vaccinated, hepatitis B vaccinated. All tick marks you should be there. They will check their titer. If you died, they take the titer their antibodies whether they have taken vaccine or not. That is also counter check. So, what are the 6 I's? One is insects, repellents, mosquitoes. The main common is malaria, dengue. Then ingestion, safety of drinking water. When you are traveling, you should have to have your own water because you know what will happen. We don't know. Then indiscretion like yes, sexual transmitted diseases, HIV also more common. Injuries, accidents, avoidance, personal safety is very important to avoid the accidents. Then immersion, schistosomiasis, helminthiasis that we can access while traveling also. Insurance, coverage and service during. Nowadays insurance has got major role. Even you are traveling to the train, there is 1 rupee, 2 rupees there for your insurance. You can see your ticket, there is marked insurance is covered. Like insurance nowadays is very important for our safety. Next please. Risk factors for acquiring illness depends on the areas of the world visited. Which country you are visited, that is important. The length of stay, how long you are staying there. Because you know that sometimes we go to the Australia or UK because the day-night pattern is there. Our team, that is acclimatization, you can learn in physiology. 14 days you should be there in that country, you have to acclimatize your health. That's why our team goes to 14 days prior to the Australian UK to adjust the environment. The length of stay, activities and location of travel with these areas. The underlying health of the traveler, whether the patient the traveler having diabetes, hypertension, any other disease, phobia, a lot of diseases may be there that may exacerbate by going to the that areas. Specific disease problem. Just I told yellow fever. We are not saying here. We won't have vaccination yellow fever here. We have to send to higher centers, Mumbai and anywhere. Yellow fever is endemic to certain areas in the Africa and South America. Unless until you have been vaccinated for yellow fever, entry is not permitted in that area. The CDC site delineates the 6 risk factors for provides interest about preventive steps. Then, just as is the meningococcal meningitis, we are given to this endemic in tropical areas. The vaccination going to the Hajj, pilgrims going to the Hajj, we are given meningococcal meningitis because this disease may be endemic to prevent access of the disease. Then malaria prevention. Just I told malaria, it is very important. Worldwide this malaria is there. But many common in tropical areas. Like India also. India is declared as an endemic for malaria. Like you must have been read in lot of 10 years back, any fever, any chilsragar is malaria. Kutlai fever hiuta pasu shakto. So there is a possibility there. Though it is declining, but the percentage is more. Anti-malarial drugs are recommended for prophylaxis of that non-immune travelers visiting malaria endemic areas. Our is also India. The Americans has to take the anti-malarial drugs while entering in India also because India is endemic for malaria. Then in areas of chloroquine sensitive area, chloroquine is required. In areas where chloroquine resistance is there, falciparum, we have to take mefloquine tablet is there, another tablet. The incidence, the Vivax is different. Then Vivax is different and chloroquine sensitive, chloroquine resistant, 2 types of malaria will be there. So for chloroquine sensitive, chloroquine and chloroquine resistance, we can mefloquine or doxycycline can be added. Chemoprophylaxis should be started 1 week before arriving in malaria endemic area and continue during the travel and 4 weeks after leaving that area. Like the Western countries, people has to come, they have to start 2 weeks while entering India. After living in India, 4 weeks they have to take. So they have to take care of their own health by acquiring the malarial fever. A health advisor should know. What a health advisor should know? If she is pregnant or breastfeeding, the travel itinerary and the sequence in which countries he visited and treated. The length of stay in his country travel will be rural or urban. The style of travel, which way he is traveling. The reason for travel, why he is traveling, for academic purpose, living or their vacation. Whether the traveler has any underlying health problem, diabetes, hypertension, then any other phobia, neurological problems, that also be more concerned because they may exacerbate the situation by depending upon the diet, habit and environment. Some allergies may be there. Some people are more allergic to very severe cold. If you go to Kashmir and all this, you become more allergic. Some patients have chronic obstructive pulmonary disease, allergic bronchitis, bronchial asthma. They may exacerbate their disease, so you should take proper care and carry the proper kit. And previous immunization. Immunization must. Now it is a universal immunization program is there. Everybody should follow strictly. In case of female traveler, whether she is planning for pregnancy, that also you should be very careful about care of the females. Prevention. Most travel-related illnesses are prevented because community medicine prevention is better than cure. So where you are planning to go anywhere, preventive aspect you should know must. What prevention? First is immunization. You may access any disease. So available vaccines you should take. Typhoid vaccine, malarial vaccine is also coming now, and all these hepatitis B vaccine. All vaccines are very important. Then prophylactic medications. Prophylactic medications means some signs you are allergic, you can take some phenothiazine groups or anti-allergic drug, Avil, or any drug you should have to have and you should take. Then pre-travel health education. Then there is lot of different subjects are coming. That is pre-travel health education. Means what will happen while you are traveling, what will happen you enter there. These educations they will give, that is pre-travel health education. So that they have to take some medicines, probable medicine when you are traveling. You may not get in 2-3 days that medicine you should have to have with you. Because sometimes in urban, Western country they may not allow, you may not get immediately paracetamol, you may not get immediately antibiotic unless anti-doctor prescribes. If you have got fever also, you have to be wait there for 2-3 days in US, UK. So you have to have some paracetamol or medicines. Priority basis you should have with you also. Next please. Just immunization again, diphtheria, then other yellow fever. Recommended according to risk factors, typhoid and hepatitis and rabies vaccine you should take for further your safety. Next please. Routine vaccines, we are taking routine vaccines that we have to take. Routine vaccines are the immunization that are routinely provided as a part of a normal health maintenance. These vaccines are necessary to prevention of the disease and remaining common in many parts of the world. So you should have malaria, rabies, influenza, all these vaccines you should take. Recommended vaccinations, next please. Then special considerations with traveling. What are the special consideration when you are traveling? Age is important, age factor is important. By age, from birth to the elderly or our age, different diseases are common with different diseases. Childhood age, allergic commons. Middle age, some accidents may be common. Elder age, some infectious, again traumatic. Then extreme age, some degenerative diseases. You have to be very much concerned about the age of the patient. Immune compromise like HIV and all this patient on chemotherapy, radiotherapy, you should be very much aware. Then special precaution for pregnant women. Pregnant women, which medicine should not taken, what precaution will take, how do you prophylaxis and take care of the woman. Immigrant. Then chronically ill. Again chronically ill, malignancy, diabetes, all these diseases are come under chronic diseases. Students and disabled travelers are essential. Students are also more enthusiastic, they should know their health concern must. They have to take, they should not be more enthusiastic, but they should know what precaution will take to prevent the further diseases happening to us, our health. Next please. Required vaccinations, yellow fever, meningococcal meningitis. Then pre-travel health education, just I told. The traveler should ascertain the associated travel health information from specific itinerary several months to advanced in departure. This should include general health information such as vaccine requirement, prophylaxis medicine, disease outbreaks, political environment, and medical. Anything can happen if we go certain countries. Any outbreak occurs, any malaria outbreak occurs. Recently, we have viral outbreak is there. Certain country has got certain diseases which are endemic and that may happen. Next, please. Basic health kit. Just basic traveler health kit you should have to have. A medical kit is an essential item that we should have to have with you. That should be carried by all travelers to developing countries or where local availability of such resources remains in doubt. Just I told immediately if you go to certain country you will not get immediate kerosene, you may paracetamol, you may not get immediately, but you should have with you some emergency quota or that is a basic health travel kit. The kit should include standard first aid items, some bandages, then all these important lotions, and items simple medicines for common ailments, the specific for the traveler. In addition, consider having list of medication along with medical attestations signed by physician attendants need of those medication for personal use, because if you are going to the air travel for other countries, they see if you are taking some medicine, azithromycin, paracetamol, they see whether the doctor has assigned paracetamol, azithromycin for you, for your health, then and then they will allow to take the medicine. Otherwise, they will not allow to take the medicine with you for travel. What the first aid items? Which are the first aid items which are to be important, which are included are, then all these medicines, rapid injury, then medicines, tape, all different safeguard methods are there. First aid items, antiseptic medicines, soaps, bandage, all these items are included here. Next, please. Then additional considerations. Additional consideration थोड़ा clear होता है क्या? Like anti-malarial medicine, anti-viral medicines, anti-paracetamol, all these are given additional consideration. ठीक है सर? Next go. Viral fever. How to diagnose a viral fever? It is very common disease, viral fever. Symptoms like fever, chills, body ache, dehydration, redness of eye, severe body ache, myalgia, muscle pain, weakness, dryness of mouth, headache. All these including the all viruses. Which virus we don't know, but this comes under the congestion of redness of eye, body ache, myalgia, headache. All this comes under the viral fever. Throat pain, change in voice. All this comes under the viral fever. Next, please. Then causes are again ingestion, infection, body fluids, and all the bites, different bites. Just I told is malaria and all this that may happen. Treatment accordingly. Hydration is important. Not that much antibiotic is important, but symptomatic management is important. Only viral fever, treat fever with paracetamol. If dehydration, give hydration, IV fluids. That will take care of the viral disease. 2-3 days you wait it. That is self-limiting disease. Motion sickness, it is a very important part. Motion sickness, you must have been experienced by traveling to the in hilly areas and going to the Mahabaleshwar, Tirupati and all these hill station. Round ghat is there, so you are getting some giddiness. That is motion sickness, giddiness. When you are traveling, you will get sickness. Promethazine can be given. Avomine tablet 25 mg can be given. It is a type of sedative drug, so you have to take precaution, and that will take care of this, because slight sedation will be there. And avoid the drinking and all this. Consult the doctor. Don't drink the alcohol while traveling, and be alert. Take the medicines. Next, travelers diarrhea. Again, it is a very important term. Travelers diarrhea. 2-3 times I experienced in train, because they can eat. They can samosa, vada. Travel. We can use it by train route. We get down and we can eat some vada, samosa. We attempt to eat it, but we don't know what is the hygienic status of that food. So ultimately, E. coli infections, Salmonella, Shigella, all bacteria we affect and will get diarrhea within short time, and will get dehydration, weakness, and all this develop. So for that, most common is E. coli. E. coli, Salmonella, Shigella, all these are susceptible bacteria and viruses. Next, please. When counseling travelers about diarrhea, then food and water precaution you should tell it. Hand hygiene is very important. You wash your hands. Chemoprophylaxis, you take some medicines prior to having the disease. Self-treatment of illness. You are knowing some You know, nowadays everybody, all educated people have some knowledge about the disease. If they have got fever, they go to counter medicine, they have it. It's very wrong, but they go to the medical store, they get paracetamol, they get diclofenac. The side effects are very dangerous. Kidney disease may occur, any severe hepatitis may occur due to sudden allergic conditions. So, and immunization. Again, see, immunization is very big role in our health nowadays. So, immunization is mandatory. Next, please. Like viral conjunctivitis, we are traveling 2-3 days in a train. Our colleagues, our nearby some passengers, they may have the conjunctivitis and redness of mouth, change in eyes, fever. That may transmit within 4 to 6 hours. If you are coming with that person in contact, you may also have viral fever, and then redness of eyes, watering of eyes, body ache. That viral conjunctivitis may occur. But treatment is again symptomatic. Drops you can take and antipyretics. Vector-borne diseases, just say dengue, malaria and all these vector-borne diseases. You may, while traveling, you have got some mosquito bites. It may develop malaria, it may develop dengue fever. All these vector-borne diseases may access while traveling to the train, mostly in train and buses. Next please. Illness after the return. This is again important. See, illness after return, that I told. You come after some 10-15 days from your place where you have visited, then you become so more fatigued. Because you go to the Mahabeshwar or anything, there are a lot of, you go down, you go up, and in the day full you will do the running and seeing the different spots. You may not feel there anything, but after coming some days you feel some fatigue, muscle pain, cramps, weakness, all this. This may develop, so illness after is again important. Do counseling, antibiotics, full of fluids, all that is more important, and consult the doctor. If the patient have got some previous illness, diabetes, hypertension, heart disease, you check up it and proper take care that untold things should not happen in future. Next please. This is about the travel medicine. We should know about how to travel. I will tell one story. When I was a lecturer, one of the big person admitted, we know unknown person admitted in unconscious condition by traveling in train. We don't know what happened to him, but we are treated 2-3 days became he conscious. He told that I am the manager of carrier company of AC, Madras. So I think when the relatives they are coming by plane, we thought he'll give some donation to college, 2-3 carrier AC will be given. But he went away that only. But some people are, so we should not expect. But this is our duty is to treat. Don't expect anything. Our main job is to treat the patient. Patient care is our main aim. Thank you. Thank you, sir.
Of experience, and it gave us really a very deep knowledge about the travel medicine. As due to globalization and improving standards of the travel sector, we have seen that there is a lot of people are traveling to else countries. Some are going abroad for education, some are going for livelihood, some are going for jobs. So it's very, very important to have a deep knowledge about the travel medicine. Now I would like to invite our Honorable Dean Sir to felicitate our chief guest, Dr. Dhadke Sir. A big round of applause.
The important things I want to add is that chest pain, heart attacks. Again, these are nowadays, very, very common. Any patient having chest pain, sweating, perspiration, vomiting, body ache, then pain in abdomen, then having some altered sensorium, that is chest pain. It is very, very important that nowadays you are seeing young generation are affecting heart diseases. Yes, we have seen the patient, 32 years old, went under angioplasty. Comorbid condition, no any habits, no alcohol, no tobacco, nothing, 32 years, because he is alright by angioplasty. But chest pain is very important. Just our colleagues have gone to some Singapore and anywhere, the diving he has done and suddenly he collapsed. So chest pain is very, very important. You should very concerned. One, I will tell that the elderly person should carry some sorbitol along with it. May or may not be. Any patient having chest pain, sublingual, you can take it immediately 10 10 milligrams sorbitate tablet that will solve your most of the problem till you go to your place, because the sorbitate and aspirin. I advise recommend hardly take 10 or 5 to 10 rupees for 10 tablets sorbitrate. You should have to have kit with you. You may or may not be, but we should not underestimate our chest pain. I heard that one of the cardiology head of department of big institute in Maharashtra, hardly 43 years of age, DM cardiology and HOD cardiology. Suddenly he collapsed in the gate of KM Hospital, Mumbai. He was the HOD of cardiology. Age is 43. DM cardiology plus head of department. His own department, he left and in the gate he collapsed. So this is the very pathetic condition nowadays. Everybody should not, any chest pain, rule out. Do ECG, do echo, be relaxed. But don't be underestimate or neglect your chest pain, because nowadays what happen, different varieties of presentation is there. We also don't know what happened. Patient comes suddenly breathlessness, he put to entry wall AMI. Patient come with ultrasensor, he is AMI. Patient has weakness, he is myocardial infarction. Nowadays a lot of summary is there. Patient suddenly collapse, that is AMI. So chest pain, it is nowadays very, very important. So always be careful while traveling also. What sir has advised to me about chest pain, elaborate something that is very important, because we always go to the high altitude, we don't know, we think I am fit, but anything can happen at any time. We should not be over enthusiastic. We should take care. While traveling, we are doing the fitness of this Amarnath and all this, we are doing fitnesses. So do ECG, echo, X-ray chest and then go. We know you are fit, but you prove that you are fit. Do ECG, do echo, do X-ray, nothing is there, then it's okay. And don't do more exercise as age advances. Accordingly you behave, give respect to your body, because when you are 20 years old, you are young. When you go to the 60 plus or 65, 70s, that may not be the enthusiastic will be there, because these risk factors will increase as age advances. So we should take proper care of the heart diseases. Hypertension, proper medicine should be taken. Diabetes, proper medicine should be taken. IHD, proper medicine should be taken. Even though some patients having some severe diabetes, uncontrolled diabetes also. Now there are some injections are coming that there is no pain. Now deglutec pains are coming. You can immediately calibrate 10 units, inject the injection, keep in your pocket. So easy nowadays. Not necessary to keep in freeze and all this. These are called newer insulins. So you can use it, and very friendly treatment is available. A lot of medical doctors, researchers have dedicated to the livelihood of the future generation. उन्होंने बहुत करके रखा है आपके लिए. So you should have some research mind. And chest pain, heart disease, very, very important. We also sometimes very forget what happened. Suddenly 2-3 patients came, breathlessness, died. Suddenly came chest pain, died. Before we intervene, before we treat, they brought death. Because my assumption is that God has given always some intuition. 2-3 दिन पहले कुछ तो होता रहता है. What I experience is some few information, ये हो रहा है, तो you should become alert. We should always alert. Like there was one sentence, there is no difficulty in life, always life is open. I heard one sentence from one university. Then when God closes a door, he always opens a window. You should be open eyes. He closed the door, but window is open. That's why you should, there are a lot of ways are there. So you should go in positive minded, very important in lifetime. And that too, heart disease nowadays very, very big concern. I think second or third number comes. First only after accident comes is ischemic heart disease. That too, multiple habits are there, but without habit also they are stress related. You know nowadays lot of stress is there. Young medicals, doctors, there are a lot of stress under variety of reasons by patient relatives. All these things are happening. So take care of the heart disease. Tell your doctors, check regularly, take care. Some alarming symptoms are there, go immediately, take care. That is the mantra of the good health. I think we should take care of your health first. Thank you, sir.
Thank you so much, sir. Since our childhood, we are familiar with the concept of health is wealth. And as we grew older, we also came to know that service of the sufferer is the service to the God. So our health industry is a unique combination of these two points. So while doing the service or serving the people, many a times health workers themselves become a subject to a lot of disorders or a lot of chronic and acute diseases. So before giving a short brief introduction about our next speaker, that is Dr. Aarogya Nagari ma'am. She is a senior medical officer and in charge of antiretroviral treatment center present at our Shri Chhatrapati Shivaji Maharaj Sarvopchar Rugnalaya. So I would like to call upon the ma'am to share a few words on the topic ART center and universal precautions for the health workers. Thank you.
Good morning everybody. My topic for discussion is universal precautions and post-exposure prophylaxis. I think this is a very important topic for discussion among all our healthcare workers. So because last 3 to 4 months we have observed many medical students and many healthcare workers are approaching our OPDs with needle pricks, and once you get a prick, everyone is going in a panic situation. So rather than going in a panic situation, we should know the do's and don'ts regarding post-exposure prophylaxis and universal precautions. So the first thing that comes to our mind when we have when we get a prick is HIV. So before going to post-exposure prophylaxis itself, let us first know shortly about what is HIV, how HIV occurs and how HIV doesn't occur. How HIV doesn't occur is very important while working in the wards and for all our healthcare persons. Now as we all know, HIV is the human immunodeficiency virus. It mainly acts on our immune system. Our immune system is disturbed, immunity goes down and the patient gets different opportunistic infections once the patient gets HIV infection. HIV is different and AIDS is different. All patients are not AIDS patient. AIDS is a disease complex or a syndrome. Syndrome is always more than 2 or 3 multiple illnesses. So HIV infection, a person can have only infection and patient is perfectly normal. But he can infect other individuals. So HIV and AIDS are different, though both have the virus in them. So AIDS was first described in 1981. HIV is HIV-1 and HIV-2. And the first case was identified in Chennai in 1985. So this is where the HIV was first found, 1 and 2. Next. In India we have lot of HIV-1, less amount of HIV-2 and less amount of HIV-1 and 2. So this is the structure of HIV. We have to, I will not go into the details about this, but we should know the structure of HIV. So when we take any drug for post-exposure prophylaxis, where the HIV virus will, where the drug by sharing utensils. People are not eating also in the utensil in which the HIV patient is eating. That is wrong. It is not transmitted like that. Even a mosquito bite. So HIV is strictly transmitted, as we all know, mainly through sexual contact, blood products, IV drug abusers. IV drug abusers also, by substantial amount of blood has to be exchanged in the body. Then only the virus will be transmitted. Next. So now many people come to us in the OPD, I have a prick and the patient is HIV negative. That is the most important part, that is the window period. The patient will be negative, but the patient will have the virus in the body. There has to be some amount of virus in the body to be detected in the blood. So it takes around 3 to 8 weeks for the patient to become, for them to detect the virus in the blood. That is called the window period. So but in that window period, the patient is infective to the other individual. So though the patient is HIV negative, we have to think about the window period when we go for any post-exposure prophylaxis. Next. So this is the testing that we do for HIV. In our setup, we are doing the ELISA method in microbiology department. In all, there are different primary healthcare centers, there are different rural hospitals in the districts where all testing facilities are given. Testing is free of cost and it is voluntary. There is no compulsion to do a testing. And in that, in a government setup, 3 test method is done. In the rapid ELISA method, 2 test reactive is labeled as HIV positive. There are other methods are Western blot, then the P24 antigen RNA PCR and the nucleic acid. These are the higher tests. But in our setup in microbiology department, what we are following are the rapid ELISA method, with the 3 testings are done on 1 sample and 2 test positive is only then labeled as HIV reactive. Next. So as per the staging, the patient goes on and you know how the illness is. If patient is positive and patient has no complaints at all, patient is labeled as stage 1. Staging was important initially when we used to treat. We used to give treatment as per staging, but now as we have treat all policy since 2017. So you treat all positive patients. You do not wait for any stage or any count or anything to come down, and you treat all positive patients on antiretroviral therapy. Next. So what regimen we are giving in our ART center? We are always giving 3 drugs together, that is tenofovir, lamivudine and dolutegravir, one bottle, 1 tablet at night bedtime. Only thing, counseling is a major part in HIV treatment. You have to tell the patient that you have to take the tablet regularly 24 hours apart. You maintain some specific timing, because if there is no timing and you take the drug haphazardly, the viral count multiplies and the patient may go for resistance. So always triple drug therapy is given, and counseling plays a major role in the treatment part. Next. And this is the pediatric regime that we are giving in our setup, government setup. Next. So coming to the main topic, that is post-exposure prophylaxis. Next. So before going to the treatment itself, you should know how the HIV is transmitted to the host. Day 0 exposure to HIV at the mucosal surface. The virus gets collected at the cells to the nodes. Replication acts on the CD4 cells. CD4 cells are the main cells which act on the immune system. So the CD4 count goes down, that is the immunity goes down. Once the immunity goes down, patient gets different infections. So, and then the virus will spread to the other organ. This is the line how the patient will, the virus will replicate. Next. So now, healthcare providers are prone to accidental exposure to blood fluids and tissues. Occupational risk of bloodborne infections like HCV, HBsAg, HIV in healthcare personnel. So once you get a prick, only prick is not an HIV prick. Prick can be hepatitis B prick also, and hepatitis C, which is more dreadful. So rather than going in a panic mode for an HIV prick, you should always know about hepatitis B. So for hepatitis B, all healthcare workers are advised to go for vaccination as per the vaccination schedule, because everyone is working in the wards and everybody is exposed to all possible infected blood. So healthcare personnel include emergency care workers, all the laboratory, autopsy, hospital employee, all the other workers also. Next. So as you all know, we are all exposed in the occupational exposure to all these. These are the definitions regarding healthcare workers. I think we all know that. Next. So different types of how you decide on how you start the treatment for post-exposure prophylaxis. Mainly you all are getting is the needle stick injury. So there are 2 types, the exposed person, that is V, and the source. So as per the source, you should know what is the status of the source. Suppose he is a positive source, what is the viral load of the source? Whether he has a high viral load means he has a more infection. If he has a low viral load, he has less infection. Viral load testing also is done at our laboratory in microbiology department. Next. Many a times the source is unknown. We don't know from what is the status. At that time, the role of post-exposure prophylaxis is most important. So all our workers, everybody, all students and all healthcare workers are at risk of getting injuries. Next. So in this you can see which are more risk fluid factors and blood, and which are less risk. Maximum is blood, semen, vaginal secretion, and the lower ones are less in the amniotic fluid, peritoneal, pericardial fluid. Not at risk are tears, sweat, urine, feces, saliva, sputum and vomitus. Next. So if you can see the incidence of transmission, Blood transfusion 98%, 88%. Blood transfusion only when there is a substantial amount of transfusion into your body. Then only there is a risk of transmission. Then the perinatal during delivery, that is also reduced now because you are giving ART to positive mother immediately. You are not waiting for any CD4 count or any stage. You give, once the patient is infected, everybody is treated. Then sexual contact, the vaginal fluid, if you see the needle stick exposure, it is only 0.3%. So it is a very less amount of incidence of transmission. Next. So now you see the incidence. Now if you see in this slide, there are two types, the percutaneous injury and the mucous membrane injury. And in both, if you see, risk of hepatitis B and hepatitis C infection is more than in HIV prick. So everybody is advised to vaccinate themselves. You please convey the message to all your other batchmates or your friends that hepatitis B prick is also very important and you have to get vaccinated, which is most important for all the healthcare workers. Next. The other risk factors in a prick are the viral load of the patient, whether you have used gloves or no. You should ideally, when you ward in, ward out, you wear gloves and you remove them when you come out. So at least if you get a prick, it is not a severe prick as you have a cover of gloves. Then how the needle is, the solid needle or a hollow bore needle, and the drying condition. HIV virus is a very fragile virus. Once the virus gets exposed to room temperature, the virus loses its potency. So everybody, whenever you get any prick, it may be HIV, you don't know whether it is HIV, the first thing which is told is first aid. That is the most important part, which I will be coming to next. So the management of the exposed person. Next. So first aid, management is first aid. Establishment of PEP, you counsel, you assess what is to be prescribed, you do basic investigations and you follow up the person. So what first aid is to be given? Firstly, when you get a prick, rather than panicking, go to the tap, you have soap available and water available. You wash that prick area thoroughly for 20 minutes with soap and water. Firstly, rather than going in a panic situation, you first take the first aid, which is most important, and that is available everywhere in the hospital. Next. So, once you get a prick, wound and surrounding skin, you wash with soap and water and you rinse. Do not scrub. Do not use antiseptic. Initially they used to say you apply sterilium spirit or Savlon, but now they say soap and water is enough. It is easily available everywhere, and for 15 to 20 minutes if you wash the area, you will not have any problem. Do not use bleach and chlorine. So skin, blood, body fluids, unbroken skin also. We may feel we have unbroken skin, but we have lot of abrasions on the skin and there are small cuts which we do not know. So first aid is the most 99% important is first aid. And now this is for a needle stick. Suppose there is an eye splash, that is most important. Ideally you should wear medical goggles when you are working in the wards, but for any purpose you do not have that, you think about this. Sit on the chair, tilt the head back and ask the colleague to pour water and normal saline on the eye. Water and normal saline only. People have poured spirit, Savlon and what all when there was a splash in the eye. Do not do that. Water is easily available, normal saline is also easily available. And people who are wearing contact lenses, do not be in a rush to remove the contact lens. Contact lens is a very good barrier when there is a splash. If wearing a contact lens, leave them in place while irrigating as they form a barrier over the eye and it will protect. Once eye is clean, you remove the lens, clean it in a normal manner. This will make it safe to wear. Mouth, where if by mistake something goes in your mouth, rinse the mouth thoroughly using water and saline and spit again. Repeat this process several times and do not use soap. So please remember, eye splash and mouth, do not use soap. You use only plain water or if available normal saline. Next. So this is the same thing. Next. And once you get a prick, we have a habit of putting your finger in the mouth. Do not put finger in the mouth when you get a prick. So it is very important when you get a prick or a splash. Next. So once this all happens, you have done first aid. So when do you take PEP? Ideally, post-exposure prophylaxis should be taken within 2 hours of the prick, and it can be taken up to 72 hours. Assess the severity of exposure, assess the HIV status, and assess the exposed individual. But many times in working in our setup, we do not know the status of the patient and we do not have time to wait for the report. So what we suggest, and whatever drugs now we are prescribing for post-exposure prophylaxis are all safe drugs without any side effects, because we are giving it only for 28 days. So you immediately take the drug. Drug is available for 24/7 in casualty. In casualty, bottle is kept, CMO knows about it, and the phone numbers of the pharmacist and the staff nurse of the ART department are displayed. You immediately take the stat dose if you have a pre-con or non-working day. If otherwise 9 to 5 ART center is open, but immediately take the drug and you come to the ART center. Do not wait for Monday. Many people are having pricks on holidays and they are waiting. In the casualty, I repeat, in casualty, bottle of PEP is kept and our numbers are displayed, doses are displayed. Any problem regarding the doses, you can call the concern. Next. So, the categories of exposure includes mild, moderate and severe. Sometimes everything, only there is only blood is on the finger. There is no cut, nothing. That is called a mild exposure. Only that is there, you need not do anything. Or even if some infected fluid of the patient is on your hand, you need not do anything if you have taken first aid properly. If you have not taken first aid properly, then you should take PEP for betterment. Then the moderate exposure and severe exposure. This depends upon amount of blood, the depth of the injury and the status of the patient, the viral load. Suppose the patient viral load is 50,000 units, means the patient has more disease, patient will infect, the tendency to infection is more. Then post-exposure prophylaxis has to be taken. Next. So this is the low risk, high risk. As I told you, the low risk is HIV positive but clinically asymptomatic, but the patient is able to infect others. High risk is HIV positive and clinically symptomatic. So firstly, in PEP, as I told you, counseling is very important, because once you get a prick, everybody is in a panic situation ki I will get HIV now. You will not get HIV with a prick. The post-exposure prophylaxis is available now. When we were working in the wards, when we were doing cesarean sections, we also used to have pricks. That time PEP was not available. But what we used to do, you do first aid. You get a prick, you wash with soap and water, so the consequences regarding the same are avoided. You inform consent form is there regarding PEP. We fill the form, we counsel the healthcare worker, and we document everything. What was the type of the prick, type of the needle, when was the splash or when was the prick, and as per that we prescribe the medicine. Next. Deciding on the PEP, then we tell the we also do baseline investigations like blood count, kidney function and liver function test at the day of the prick and after 28 days to be on the safer side. So this is for healthcare worker. Then PEP is given even for patients of sexual assault. Many sexual assault patients come to us by unknown assault, not knowing the status. So PEP is given for all sexual assaults. Next. So the known sources and the unknown sources, but in our setup we are giving PEP for everybody, depending on the prick, not only the blood on the skin. Next. So when should PEP be started? As I already told you. Next. Within 72 hours preferably, and ideally within 2 hours you should take PEP. It should be available in the emergency department. So it is already available in the casualty 24 hours. You please convey this message to your friends also. Next. So this is the exposure code as per the severity of the prick, and if you have to give PEP to whom and you do not have to give, already spoken about it. Next. So the source, whether the patient is having a high CD4 count, that is the high viral load count. High CD4 means patient's immunity is better, low count means patient has more disease. As per that, you can decide what is to be done. Next. So this is how you decide on when you don't give what is recommended, and consider PEP if HIV prevalence is high in a given population. Population means there are high risk population like IV drug abusers. Suppose they come to you and his friend is having prick from IV drug. So you know that that is a high risk population. Then female sex workers, these are other category of people. Then you advise PEP for such people. Next. So recommended PEP regimen, as I told you, in adults, tenofovir, lamivudine, dolutegravir, the 3-drug regimen in one single bottle, only one tablet at night, at bedtime, after food for 28 days. If it is a child, then depending on the weight band, you give zidovudine, lamivudine, dolutegravir or lopinavir, ritonavir, depending on the weight band and depending on the age and depending on the hemoglobin. Next. So the side effects, there are very few side effects with the adult regimen. There is no nausea, there is no vomiting. Initially we used to give efavirenz drug regimen in which there was dizziness and there used to be nausea, but the drug which we are giving is a very safe drug. But still, to be on the safer side, baseline investigations and investigations after 28 days is most important. Next. So the recommended baseline investigations, as I all told you, again in many slides if you see, along with HIV, HCV and hepatitis B is also written, which is most important. Next. So how do you follow up? You follow up after 6 weeks of the prick. You can do an HIV testing of the individual, or if there are any symptoms regarding the same like fever or any diarrhea, you can see. But ideally up till now, whoever has taken PEP, whoever's HIV we have repeated have not come positive, and with single prick and with such a small blood splash and with proper first aid, no one will become HIV positive in this way. Next. So you monitor, as I told you, you monitor for the, you look for the signs and symptoms. You first refer to the ART center, and once you get a prick, avoid blood donation, breastfeeding, pregnancy. Person should also use contraception, and adherence and adverse drug reaction counseling is most important. Next. So again, this is the path: assessment, counseling, prescription and follow. Counseling plays a very major role. Next. Next. So recapping. So most importantly, what everybody is doing and how you get a prick is while recapping. Once you draw blood, you should keep your bulb at the bedside and do not be in a haste or in a hurry. Once the blood is drawn, do not recap. Needle should go to the needle cutter and the blood should go in the bulb itself. You are always in a hurry to recap. Once you recap, maximum pricks are with recap. So this is the site where you are getting pricks. Always get the blood at the bedside. Do not panic. Keep your mobile phones away. So you will be concentrating on what you are doing, and then you will avoid such kind of things. So recap previously. So recapping is avoided. Previous slide. Previous. Transferring a body fluid between containers, handling and passing needles or sharp objects after use, failing to dispose of used needles, and poor healthcare waste management practices. So you should be very careful while dealing with blood and blood products in the ward. Next. So this is how they are showing recapping, which should not be done. Next. So strict compliance to standard workplace precautions, avoid use of injections where safe and effective alternatives are available. If you can give oral therapy, most importantly you can prefer oral, so injections are avoided in certain situations. Avoid recapping and proper care. That is the same thing in this slide. Next. So this is again the same. All hospital and staff members must know whom to report to PEP and availability of PEP drugs in case of occupational exposure. I repeat, PEP is available in the casualty 24 hours. Next. So always use protective gears. Consider all samples are infective. Then you will accordingly work properly, slowly, and you will not get any pricks. Follow universal precautions, which is most important. practice safe handling of sharp instruments, and use needle destroyers. Next. So this was in short about post-exposure prophylaxis and universal precautions. Shortly, I would like to talk about our center. Our center started in 2007. We have done 2 research studies up till now in our ART Plus center. ART Plus center is the only center in the district of Solapur which gives all 3 lines of ART, first, second and third lines in our setup. Next. So this is our staff situation. 3 centers available in Solapur. Pandharpur and Barshi are only ART centers. All 3 lines are available in our center only. We are linked to all 5 other centers where patients who are regular can go there and take the drug. So it is easy to get the ART. Next. So this is how our center functions. Patient first comes to the care coordinator. Then the counselor. Counseling is very important because of social stigma. We should also tell in the society now, as we know how HIV doesn't occur, so that patient doesn't face any social stigma. You enter the patient, you counsel, you do investigations, you put the patient on ART, you follow up. So before treatment, after treatment, every month patient is counseled properly and investigations and everything is carried out. Next. So facilities available are all 3 lines. All our basic investigations are free of cost. CD4 viral load testing, which costs around 4,000 to 5,000 rupees, is done in the microbiology department. All deliveries we do with universal precautions. All patients admitted in our medicine department and respective departments. Dialysis of HIV patients is done only in civil hospital in the whole district. All surgeries are also done, NICU, pediatric, everything we give for HIV patient. Schemes that we are giving are all these: Sanjay Niradhar, Bal Sangopan, free transport and free nutrition to the children. Next. So this is our data. Up till now we have 20,000 patients registered. We have 6,500 on ART, and second line, third line, post-exposure prophylaxis we have given to 466 healthcare workers. Tuberculosis treatment also is given in our department only. Prevention of tuberculosis treatment also is given in ART center. Next. So this was a short about our COVID pandemic. In COVID pandemic also all our staff members have worked very hard to deliver drugs to patients in all the containment zones, so patient does not miss the pill, especially in the first wave when there was a strict lockdown. Next. Next. So 878 areas were there, patients were benefited in that, in the link centers, and in all our patients we were giving proper medications. Next. 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 These were all the awareness programs that we have done. Next. 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 This was World AIDS Day. Next. This was a paper presentation. Next. Next. So this was our goal. This is our WHO goal for this year, putting ourselves to the test, achieving equity to end HIV. I thank Honorable Dean Sir, Jaikar Sir, Ladke Sir, V.M.G.M.C Madam, Savaskar Madam and all the faculties for inviting me for this guest lecture. I also thank the administrative officers and all paramedical staff residents for helping in the Aarogya Nagari program. Special thanks to Rohit Tapriya and all these students who have done this venture. Not only they came up with the concept, but they saw to it that it got materialized in such a successful manner. And I am also a student of this college, and I am extremely honored and privileged to be a part of this venture. Thank you.
Thank you so much, ma'am. It was really an honor to listen to you. I think the most important topic which was focused today or planned for today. So I would like to invite Dr. Dhadke ma'am, Associate Professor in the Department of Medicine, to felicitate Dr. Agraja Chipnis ma'am.
Anybody have any questions? Can you please come and ask?
A big round of applause. So before concluding this morning session of the conference, I would like to say that whatever the chief guests they have spoken, it is to promote some good skills and improve our knowledge. And we must not just take knowledge but also try to implement it in our daily life. So in our afternoon session, we have our special guest, Dr. Jagannath Dikshit sir. As you know, he is famous all over the nation for his special Dikshit diet, which has impacted don't know how many lives, numerous lives in the nation. So I would like to call upon you to in the afternoon at 4 p.m. to listen him over here. Thank you so much.
Whenever people came for elective operations, we explained them that you should not undergo operation during this period of time, as the complication rate is 20 times more. So now we are observing, after the pandemic has settled, there is a sudden surge of people because their illnesses did not improve on their own. The illnesses stayed like that. They had just avoided the operation during that period, and also we had advised them to avoid the operation during that period. But now they are coming in large numbers to get operated. So the people have understood the gravity that whenever they go to the hospital, they just cannot expect that everything will be cakewalk and they will be alright. So here I just saw an advertisement from LIC. That's a funny one, but it tells us what can happen. So there is a magician standing on the road and performing the arts. So he says that I can turn a man into a pigeon and a pigeon into a man. So one family of a husband, wife and child are standing there. So he calls the man. The man is unwilling, but his wife and son says, go daddy, let's see what happens. So he says some mantra and the man is transformed into a pigeon immediately. So everybody claps. And then he says, no, I'll convert back into a man. And then there is a guy with a balloon. So that balloon leaves from his hand, the balloon goes up and the pigeon also flies up. And now the mother and son are watching where my dad has gone. The dad is among the hundreds of pigeons and they can't identify who is their father. So these types of things, the corollaries of this or the analogy of this is that we have closely observed. Earlier it was observed only in a few families, but now every family has experienced it during their either from their own family relatives or from their near friends, that someone who was hale and hearty can suddenly develop a problem and can lose his life or can become dependent all throughout his life. So I think this has, and also all doctors, we told the people that about the prevention, that you should do exercise, you should do steam, you should do breathing exercises, all these things, and then precautions of washing hands, wearing masks. So these things have inculcated the habits in people that yes, we also have to do something to keep our health maintained. And whenever we go to the hospital, we have to expect that anything may go wrong at some time. So the acceptability has slightly improved. This I find is the change of the mindset of people coming to the hospital.
Good evening, friends. Actually, we have faced a big thing during last 3 years. It was very unfortunate to have such type of pandemic and such type of huge loss of human power, manpower as well as wealth. We have a lot of morbidity and mortality, but still, as a healthcare provider, I'll say that we were lucky to see 2 pandemics during last 12-13 years. One initially about swine flu, and then we have seen COVID-19 pandemic, and we have learned a lot. Actually, when we were not prepared to face, in spite of having swine flu pandemic, we were not prepared to face COVID-19 pandemic. We were not having a proper healthcare system, proper healthcare industries to face such type of pandemics, and we were nowhere. And from there, now in post-pandemic era, we are everywhere. We have learned that no patient in initial few days, no hospitals, no patients, everything in civil hospitals, and no private sector was involved. And immediately within few days, it was the total transformation we have seen. The private hospitals were flooded with the patients, civil hospital flooded with patients, and the same thing about our laboratory things. There was no test. We have evolved from no test to lot of tests, thousands of tests of different types. And this was the post-COVID change we have experienced in our hospitals as well as community related to our health care.
Yeah, as Madam and Sir has been pointing out, the burden has been huge. It has been tremendous, and we were not really prepared to handle the pandemic. So we were all derailed because of that. It taught us a lot of lessons. And that's what made us realize the importance of telemedicine. Now, telemedicine and telehealth, it was already there, but not practiced as widely, or it was not as huge, plus e-mental health systems which came up. So, Sir and Madam, please could you add up something on that?
Really, it helped us as a laboratory person. I'll say that when we started using the instruments, actually we have seen that lot of PCR labs evolved during these days. Lot of technology came into existence during these days, and now it is continued. Now we are ready to face any type of virus and just have kit and go for the diagnosis. It is now very much possible because we all know that it is a viral era. We don't know which virus is in pipeline. But we are ready for it. We have molecules, we will create the kits and we will start doing the diagnosing the patients, and definitely when we diagnose properly, we are going to treat the patient properly, manage the patients properly. So this is one thing with the technology or biotechnology, molecular biology, which we have evolved during these days, and along with it telemedicine. Of course, it has helped a lot even to hospitals, small clinics, as well as to in private sector as well as in government sectors. We have seen that telemedicine, which was banned once upon a time, it was prohibited, phone consultation prohibited. Now it is very much legal and we can go for these type of consultations, and it is possible. We are able to immediately send the emails or by WhatsApp the results whatever laboratory is giving to the patient, to the doctors. We have good WhatsApp groups which can share the results of the patient, share the status of the patients, and we are able to manage the patient very well in this post-COVID era. Thank you.
During the COVID pandemic, the e-medicine helped a lot because there were certain things only to be monitored, like the pulse, the BP, the temperature, and the export. So there were not many things to be monitored, or there were not many things to be diagnosed. Once a test was done and it was diagnosed as a COVID or a non-COVID, so accordingly they could follow it up, and people were scared to go to the hospitals to meet the people, to go outside house, and they were not allowed on many occasions. So there it has helped a lot. But going ahead, can we apply this to our normal day-to-day medical practice? I have some doubt in my mind, because where it is being practiced in the developed world, there the literacy rate and people have been educated to use it. Now here, when a person is going to take, say for example, my consultation, neurosurgical consultation, so whether he is able to properly communicate what problems he has, and like in my branch, the clinical examination is being emphasized a lot. So how much will I be able to diagnose, how accurately, and how can I start the treatment? I personally feel that the first consultation, as it has been talked around and it is been hyped, that from the remotest area, doctors in the urban city, doctors in Delhi, Mumbai can give you the diagnosis and go on treating them. It is good for a follow-up. But even for a follow-up, for the branches which are facing the patients and which are facing they have to clinically examine and diagnose the things. So in that, I think we have to go a long way to apply this to the day-to-day practice. It can be used only for the follow-ups or for the maintenance therapy. But even if something new happens, then it becomes very difficult. So when I was in school, the computer started. So people were very excited and they told us, You know, by the time you become doctor, it is going to become very simple. Ask the patient what are his symptoms and feed it to the computer and you will get the diagnosis. Now about 40 years have passed from that, but we haven't reached the stage. Yes, we have reached the stage in machines. So whenever we have a two-wheeler or four-wheeler, we go to the maintenance room, they apply the laptop and they find out the problem. But still the number of parameters to be checked and to be analyzed in the human physiology are so huge that still we haven't been able to reach the stage where we can diagnose the patient only depending on symptoms and signs. So these advances in e-medicines have helped us to set up the clinics and the laboratories and the other infrastructure in a short span of time. It has helped to maintain them efficiently, and it will help us when fixed parameters have to be monitored. But if you have to have a new patient and only on an e-consultation or even on a video call to examine and diagnose, I think we honestly have to go a long way until we reach that stage.
So though remote care is possible through this telemedicine and telecommunication, still what sir is trying to emphasize is that the doctor has to reach the patient even in the remotest of the area. So one thing which has been done is that the large chain of hospitals which are there, they are going over to the remote. I mean, they are tying up with the local doctors whosoever are practicing over there, so that the health services reach up to the remotest part of the country as well. Now, it has also increased health awareness and awareness regarding different kinds of insurances. So government policies have also sped up. So could you add something on the different government policies which have helped or will be helping patients now?
The government is doing an excellent work. We'll take an example of a national tuberculosis control program. When earlier I used to have a patient of tuberculosis and I had to do the gene expert or the PCR test, the patient had to spend 4,000 rupees for that. Now I just have to call a person and give him a sample, and the diagnosis is given to me. The medicines are supplied to the patient for 1 year, 1.5 years, 2 years, or whatever time is needed. In addition to that, when his Aadhaar card and account is linked to that program, so every month in his account he gets 500 rupees to eat nutritious diet. Programs have been devised excellently. Unfortunately, we have to be aware of our rights and we have to see to it that it really reaches the common people. I'll tell you my example. Many of patients come from Gulbarga to Solapur. So whenever we operate a patient, we know he has tuberculosis. So we call the local the health assistant is called to come and register him. So he comes behind my back, he tells the patient that you are from Karnataka, you go to Karnataka and get it registered there. This poor chap goes to his village in Karnataka, that guy says you have been operated in Maharashtra, you go to the Maharashtra facility. So he ends up buying his own medicines. One of my batchmates is a district officer in this program. I called her up. So she said, just ask the health assistant to give it to you in writing that because the patient is from Karnataka, he will not register him. I did that and it worked like a magic. Now all my patients, they have a software where in Solapur the patient is diagnosed. They feed his PIN code and his address there. The health assistant in his village gets the information and he can seamlessly give the services. The schemes are being devised with a great idea. This scheme, I would say, is very beautifully designed. Unfortunately, the way it works, the hitches, we doctors or the health providers, we have to be active to stop these people who are hindering these services. So another example is that they provided tube to collect the sample. Now when it started, they came to us and they gave 2 or 4 tubes. After 6 months, we thought that no, let us take advantage of this scheme. So again we asked them, we want to give a sample, give it in the tubes. I said the tubes are lost. I don't know. Hand out the tubes and give it to them. So again I called up my batchmate. He again said, you ask him to give it in writing. He came back and he gave the tubes. These things, we as health provider, for the systems to work efficiently, we have to insist. What happens? We are busy. Patient says they are not doing. I said, okay, can you buy this? he says, okay, I'll buy. And they end up buying. So the government is developing really good schemes. They can be used very efficiently, but we have to see to it that we insist, because these common people, they cannot be in any position to fight with the people, the volunteers, or the people who have been empaneled to work for that. So we have to use our good offices to see to it that these schemes, they work very well.
Actually, we all know that GDP for health sector is really was really poor in initial days. It was just less than 2. Now, during this budget, the GDP has been increased. Everybody knows, and this is, I think, post-COVID effect from government side. And now we are leading towards cashless type of healthcare systems. In other days, we have to carry a lot of money with us in our pockets. I have seen in mirrors, Mission Hospital and other hospitals, that people coming with the bags full of money and putting into it. काय पण करा आमच्या पेशंटला बरं करा हा पैशाचा गट्टा समोर आहे. Now it is not needed because we have seen during COVID, Mahatma Phule has worked a lot. So many people have been treated with the help of Mahatma Phule, because at that time nobody was having money with them, and it has helped. Now again we are, government has brought the schemes like NDHM, Ayushman Bharat, and definitely like Western countries or like US, we will be leading. We will be one day having only cashless transactions during in healthcare system. We never know, but still people are not of that mind makeup. Gradually we may change to completely cashless, and so many insurance companies. Only LIC we were knowing in old days, but nowadays it is not like that. So many insurance companies have landed into the healthcare system industry, and they are catering so many health insurances to people for accidents, for long disease. Only thing, we have to read the form properly. It's very much needed, unless there are chances that we may miss something and later we will be in trouble. Thank you.
About the insurance, what Madam said is absolutely proper. I honestly feel that no insurance company has been started because Dr. Katikar should get good health at no cost. All insurance companies have been started for their economical benefits. So their plan, their MBAs, their managers, their idea is to get as much premium as possible and give as less compensation as possible. So here we have to be very sure about what is being done, what is being offered to us, and whether it is correct or not. So unless we go into those details, on many occasions it happens that you have an amount for such a thing, such a disease, and the amount is much higher and you are not sanctioned for that. In addition to that, the government schemes also, the government is trying to develop new schemes, but I am not trying to blame someone, or I am not trying to point the fingers towards someone. But whenever a new scheme is highlighted, people get an idea that it is going to work like a magic, and nothing is going to, and everything is going to change overnight. It is not possible. The infrastructure, the system will take its own time to work. Like for example, everybody, we have heard and seen the news about the Rajasthan strike of IMA. The Rajasthan government overnight said that all hospitals should treat accident patient 48 hours for free. So everybody panicked, and everybody said, no, what is going to happen? All the hospitals are going to close. Now the hospitals will start their branches on the borders outside Rajasthan, and people will have to go there. So ultimately what has boiled down to that all hospitals more than 50 bedded who have all the infrastructure to treat the accident victims should treat first 48 hours as free. So then in Maharashtra also it is like to see, one state announces, the other state, it's a peer pressure on them that they have to announce this thing. So in Maharashtra also it is. So somebody asked me, so it is going to affect us also. So I said what they say, for first 48 hours, do not insist on paying advance. If somebody is willing to pay the advance, they are not stopping us. They say somebody doesn't have. So then my accountant said, sir, पण आपल्या दवाखान्यात आपण कुणाच्या मागेच लागत नाही तर आपल्याला काहीच फरक पडत नाही. So all these schemes, there is a euphoria that everything is going to change as a magic. And in administrative, there is a point that we are going to be doing. Nothing of that sort happens. So whenever a new scheme is announced, it has to come in place. There are going to be teething troubles. In first few years, we will understand what are the advantages, what are the drawbacks. Accordingly, they will be changed. So there is a euphoria and panic about the new schemes. I think it is to be avoided by the general population as well as the administrators.
So it has also led up to speeding up of different schemes like Health for All mission. So Ayushman Bharat, National Digital Health Mission. So government is now on the forefront to speed up all these schemes in order to benefit the general public as well. We were all familiar with the word RT-PCR. In fact, it was all there in our textbooks. But this COVID-19, because of the COVID-19, I think these services have now reached door to door. So there has been a huge amalgamation. The large centralized laboratories, they're reaching up to the lower end laboratories at different peripheral places as well. So Madam, please add something on this.
Actually, this is the need of time, I think. Decentralization of health services is very much needed now, and it will happen in due time, because till the root we have to go and cater the health services, and it is possible by decentralization. And as she said, RT-PCR, we were not at all aware about even PCR. What is RT-PCR? What is PCR? What is conventional PCR? But now everybody knows what is it, and now with this advance, and again now we are being helped by AI, artificial intelligence. Now it is also, just day before yesterday I read that American doctors, they are taking help of AI to for the day-to-day treatment and management of patients. So now digitalization and all these things, use of AI, all these things will reach to root of the population, and everywhere, even small villages, they will be, you have seen that during this pandemic, it was possible to collect samples even from small villages and small padas, and they reached to government hospitals, private hospitals, and we could diagnose, we could collect a lot of data out of it, and we could control by vaccination. Without data, it was not possible to vaccinate in this huge population, and vaccination which we did successfully have curbed and controlled the pandemic in our country. We were very much successful about it, and so it is possible with advancement of technology, it is very much possible to conquer on such type of pandemics or even diseases nowadays. But now, after COVID, we are facing communicable diseases as well as non-communicable diseases also. In long COVID, we have seen non-communicable diseases which are affecting heart, lung, neurological system, even skin, and even brain and mental system, our psychological system also, which again needs to be cared of during this post-pandemic era. And it is also possible with this AI, I think. We need to learn, we have to become techno-savvy, and we have to take help of all these things and go to each and every element or part of our society, I think.
So apart from just the treatment of the patient, the surveillance systems have also been improvised, plus the data analysis. Data analysis is very important. Why? Because history always teaches us. So this is the data which is there that is going to teach us and give us benefits for the future treatment. Now online, everything has been online due to the COVID era, from schools to colleges, conferences to research. So this is Zoom bombing. So in this era of Zoom bombing, is everything advantageous, beneficial? No, even the wrong kinds of thing comes to us. So what do you have to say about that?
There is a WhatsApp which nowadays is called as a WhatsApp University, or the forward university. Nobody is willing to check the authenticity. So even if you tell them this is wrong, they say, oh, I'm sorry, I did not check, that just came to me and I forwarded. So So we always have to find out, like some person has told, whatever we are being forwarded, is it important? Then it is not harmful. Then is it correct? And the third thing, is it useful for others and not harmful for others? So unless we use this sieve, just forwarding the information, because what happens when somebody, suppose I am a doctor, I am a part of a non-doctor group, and I pass there just casually, which I should never do, but it is happening nowadays again and again. People take it that I have seen it, I have checked the authenticity, and then only I have transferred it. So that I think is very wrong. People who are educated and in a high post, and because of their education, people give some more authenticity to their messages. They have to be very careful about this. And about passing the laboratories to the remotest places, as was the earlier point. So it is my observation that whenever a new thing has to be started, the new thing has to be developed in the periphery, whatever are the criteria are given by cut paste. Whatever criteria are used in Europe and America, they are only cut paste and forwarded here. So when they wanted to start the RT-PCR in Solapur, Madam will agree, none of the labs in Solapur could qualify to do that. So like we say, we have to adapt to the Indian circumstances. So in a similar way, whenever the newer things are in pandemic, everybody was in a hurry, but now nobody is in a hurry. So now we have to see to it that whatever norms, whatever the guidelines they have, they should be in accordance to whatever facilities are available in the peripheral areas in India, not like whatever are there abroad, they are just cut paste and submit.
We have had one very much important gadget in everybody's hand now. Post-COVID era, everyone for money transaction. कारण आपण हातात नोट घ्यायला सुद्धा घाबरत होतो. त्यामुळं फॉर मनी ट्रान्झॅक्शन, फॉर इन्फॉर्मेशन आणि ब्लास्ट ऑफ इन्फॉर्मेशन वी हॅव फेस्ड. आणि मग आपल्यासाठीच नाही तर इवन छोट्या छोट्या लोकांसाठी सुद्धा, अरे डॉक्टर ये गुगल काय म्हणते बघा, आणि व्हॉट यू आर टेलिंग टू अस, इट इज लाईक दॅट कंपॅरिझन ऑफ नॉलेज अँड इन्फॉर्मेशन स्टार्टेड विथ अस. And really at that time it is now will be difficult to face such type of patients who are Google प्रेमी आपण म्हणू, आणि मग त्यांच्याकडून जी इन्फॉर्मेशन आपल्याला मिळते, तर in that case we have to again inform them, or त्यांना आपल्याला नीट सांगावं लागतं की एव्हरी टाइम इट इज नॉट ओनली इन्फॉर्मेशन विच वी आर युझिंग फॉर यू, इट इज अवर नॉलेज अँड इट इज अवर एक्सपिरियन्स विच वी आर using for you. So this type of again difficulties in practice we are facing during this post-COVID era.
Has medical tourism flourished in any way post-COVID, or has it been the same?
During the COVID, we went back. People were better being treated in their villages or in the nearby places. So I think the answer is in negative. During the COVID period, we were not encouraging people to travel. People who felt they will get better services, they understood that they have to run from pillar to post to get even a bed there. And we have also seen that the people who were treated in the mass center in villages, majority of them have done well. So I think this is for us to learn that traveling far away for illnesses, how much it will help. For the specialized services which are not available in that place is okay. But I think the COVID has taught us a lesson that if properly applied, your local areas can also cater to the basic medical needs.
After COVID, many more clinics and hospitals have been evolved. आपण बघतो खूप सगळे हॉस्पिटल्स आले. इवन अल्टरनेटिव्ह मेडिसिन पीपल हॅज कम अप विथ देअर क्लिनिक्स अँड हॉस्पिटल. So I think this is one change we are experiencing after COVID. They are inclined towards the alternative medicine. Secondly, again though we are against cross-pati, Ayush medicine is evolving, and each and every hospital, civil hospital, is supposed to have one Ayush OPD. Then we have seen that these hospitals, the important thing, because private hospitals are increasing, we think that these private hospitals or private health sector should be strengthened nowadays, so that, and with perfect PPP module, we have to work with government so that such type of pandemics or such type of problems will be tackled very easily.
So no doubt there has been a definite revolution or innovation in the healthcare systems, the delivery systems, legislative systems, and also the hospital management systems. I think I'll just allow one or two questions in the audience if anybody would like to ask anything. Not many, but one or two. I think we should, if in case you don't want to add anything. Sir would like to say something.
World is after the pandemic, first of all, digital payments everywhere, auto rickshaw, you buy a pan, you can pay by Paytm. This is a revolution that has happened, and you will be surprised to know that more digital payments are happening in India compared to USA. If you look at it, so we have grown that much, and lot of things have happened like consultations. Various apps are developed, so things are going I think in the right track, and slowly what is going to happen possibly is for diagnosis people would go to the doctor, and for follow-up and everything they may be online, so it will reduce the crowd in the clinics, in the hospitals. And audiovisual aids are also useful for people, so a lot of good things have happened. Of course some bad things, like because there is no control over all this technology. Artificial intelligence is coming in a big way, and if you say something to the chat GPT, you are appearing for exam and it give you a question and it will give you a very good essay written very easily. Of course now the rules should be coming for controlling AI also slowly, but as of now we are far behind than people who are developing the AI, so there is a long way to go. Of course, every new technology, every new thing coming has always, it is a double-edged sword. So, unless you use it properly, it can be harmful. So, thank you for giving this opportunity. Thank you.
Pandemic. That period was really bad. We suffered a lot because we were not knowing anything. It was a blow to us. Everybody was not knowing what to do. World was not knowing anything, but out of that, few good things have come out. One thing, the patients have started relying on their local doctors. Means the local doctors, means they have started taking treatment from them. That is really a good thing. Means previously the patient used to go to some outside city to take the consultation, but they have started taking consultation from them. Then the next thing, that patients have become little bit aware of their own health. Means now for small problems, they can consult their doctors on telephone as well as on WhatsApp. And government has allowed this consultation. Previously it was not allowed. Means you were not allowed to give medicines on phone or WhatsApp. That has been permitted. After first consultation, you can consult the doctors. And the vaccination, this vaccination program has come out very well. Means the people started taking vaccines, all were made aware of the vaccination. That is a good thing. And not only the COVID vaccine, but the other vaccines like influenza, then pneumococcal, meningococcal, hepatitis B vaccination programs, they have come out very well. And as there are a lot of good government schemes have come out, and the government has done a lot of good things for the people in the form of Mahatma Phule, Ayushman Bharat, then Vajpayee Yojana. So these are the good things which have come out of this pandemic. Okay, thank you.
Thank you, sir.
Doing that, antibody is tighter and.
During that COVID-19 pandemic, our department, our institute carried out the Zero survey, that is Zero surveillance. It was carried out in urban as well as rural area under the guidance of district collector and our dean sir. And in that survey, we observed that 80 to 90% people in urban and rural, they had an immunity against the COVID-19. This shows the effect of COVID-19 vaccine in the reduction of morbidity and mortality after implementation of COVID-19 vaccine. That is, new vaccine, COVID-19 was new, vaccine was new, but it helped a lot to reduce the morbidity and mortality due to COVID-19. And our central government, that is Government of India and Government of Maharashtra, handled COVID-19 pandemic in a nice way. In spite of having huge population, we are having scarce resources in terms of manpower, paramedical staff. The case fatality rate, it was less as compared to developed country. That is, we handle COVID-19 pandemic in a better way than the Western countries like America and England. This is our success. I want to say we handled it very well. Thank you.
Yes, if there are any more questions, or I would like to conclude this session. What I say concluding remarks would be that COVID-19 has made me at least, and all of us mostly, religious, because we have been from a stage of devastation, but we have successfully handled the pandemic and we have bounced back. We had a lot of loss in terms of humanity, but the way we have bounced back, that has made us religious, all of us. Thank you. Thank you very much, sir, madam, and all of the present.
COVID-19 pandemic has made the people religious. So in fact, it is the greatest step which has taken by the era. So now going further, I would like to invite Dr. V.M.G.M.C sir to felicitate Dr. Jagannath Dikshit sir. Please. Now, expressing our gratitude towards the wonderful panel discussion, I would like to invite Dr. Santosh Hararkar sir to felicitate Dr. I would like to invite Dr. Santosh Hararkar sir to felicitate Dr. Vijikar sir. Thank you, Dr. Katikar sir. Now commencing before the next session, I would like to add something brief about the topic which is going to be spoken by Dr. Dikshit. In our today's world, from my childhood, a really amazing thing has been observed. Can you all guess what is that? Well, I observed that in a recent WhatsApp post, there was a very beautiful image in which before our few generations, the TV was very stout and the man was very lean. But now, there is an opposite scenario that the man is becoming stout and the TV is becoming lean. So yeah, I'm talking about the obesity, which is a serious problem for our generation. And you know that we are ourselves responsible for it. Yes. Well, getting the minds cleared of this question and giving a new direction to the India's fight against obesity, I would like to invite upon the world famous Dr. Jagannath Dikshit sir, who is famous for his Dikshit diet. As we all know, it has changed the lives of millions of people over the nation. So I would hand over my mic to Dr. Jagannath Dikshit sir to add his insightful words.
For the Diamond Jubilee year of this college, and I know many students and staff of this college. Since many years, I have got good relations with people in this college. Dr. Burte was pharmacology professor in this college long back. And, he was with me at Nanded. We used to play lawn tennis. Dr. Raite madam, who were from my subject, I knew many of them. Are we ready? And with the students contacted me, Rohit and Kshitij, and I was very happy that the students have organized the event in a very graceful manner. So I congratulate the organizers for organizing such a beautiful program. You can clap for Any problem in the? I will be talking on a subject which will be of immediate use to you. Make it slideshow. Are you able to see this? Last page. Are you able to see this? Okay. I will request you to raise your hand if none of your relatives is having diabetes. Is there anybody? I ask you to raise hand if none of your relative is having diabetes. So everybody, every house has diabetes. Recently ICMR has presented its study and you find there are 10 crore diabetics in this country. And the number has increased by 44% in the last 4 years. And the work that we are doing, we find there are about 10% diabetes and about 20-25% pre-diabetes. So normal people, the number is going down slowly. So this is a topic of importance to each one of us. You may not have diabetes, and if you have diabetes, it may be a type 1 diabetes, where this lifestyle will not help you. But whatever I am going to tell you today, if you tell this to your relative who is having diabetes, type 2 diabetes, I can assure you that your relative will be off medicine in a matter of 6 months to 1. Only thing, you have to listen carefully to what I am saying, and then you can guide your relative. This is called Dixit lifestyle. People used to call it Dixit diet, but for me it is Dr. Jiskar diet. The story started in 2012 when I was trying to lose my weight. One of my friends gave me a lecture of Dr. Shrikant Jiskar. I think most of us must be knowing. He is a very eminent politician, doctor, and he had to his credit highest postgraduate university degrees. And his name was in Limca Book of Records that time. 1997 to 2004, he propagated this lifestyle that I am propagating now. And I watched one of his lectures on YouTube. So we are talking about technology, how good or bad it is. But all these campaigns started because of a YouTube lecture. I couldn't meet Dr. Jiskar in time because he expired in 2004. I couldn't meet him, but it was the lecture that inspired me to experiment on myself. I lost 8 kg and 2 inches. And then I started propagating the idea. So all the credit and all this campaign as well as this lecture is dedicated to the memory of late Dr. Jiskar. Next. Now because I am talking to medical students, I will not give a popular lecture because you can go on YouTube and you can listen to those lectures. They are 1.5 hours, 2 hours lectures. But this is a technical lecture for doctors. Now all of us know that raised level of insulin called hyperinsulinemia is bad for you, and everybody accepts it. It will cause you will put on weight, you will have more chance of getting heart attack, your bad cholesterol will increase, your blood pressure will increase. So nothing good will happen if your insulin increases. That is known to everybody. There is nothing new that I am taking. Next. The principle behind the lifestyle is if the insulin level in your body increases, you become obese, you develop insulin resistance, and then type 2 diabetes. This is the theme. This is the principle behind the lifestyle. Next. Now coming to the insulin secretion, how it really happens. Unfortunately, if you read your Guyton or any first year physiology book, you will not find how insulin is secreted actually. When I read the Williams textbook of endocrinology, I came to know that insulin secretion happens in 2 ways in your body. There are 2 ways. One, we call it baseline secretion. Now baseline secretion means 24 hours, the pancreas would go on secreting small amounts of insulin, 24 hours. And that amount is about 18 to 32 units per day. And the peculiarity of this secretion is, it is beyond your control, it is involuntary in nature. So you cannot do anything about it, that is going to happen. The second way of insulin secretion is, every time you will eat, you will secrete insulin. Every time you will eat, you will secrete insulin. Now it is expected that out of the total insulin that you required in a day, half should come by baseline method and half by your eating episodes. So 18 to 32 units by baseline, 18 to 32 units by your eating episode. That is what is expected. Now there are three peculiarities of the secretion of insulin that happens because of eating episodes. The first peculiarity is, every time you eat, you will secrete a particular amount of insulin. Now this particular amount is different for different people. For some it may be 4 units, for some it is 5, for some it is 10 or 20 or 25. It can be anything, but it is different for different people and it is a peculiar amount. So every time that person will eat, he will secrete that amount of insulin. Second peculiarity is, if a person secretes 5 units of insulin by eating 1 apple, and if you give him 2 apples or 3 apples, then also he will secrete more or less 5 units of insulin. And this is an area where the physicians are not with me. There is a controversy because the reason, they also want to reduce insulin resistance. Physicians also want to do the same thing. We are also doing the same thing, but they feel that eating small frequent meals, because you give less food, you will secrete less insulin. That is their idea, which doesn't work, unfortunately. So the second principle, second peculiarity of the secretion is, whether you eat less or more, you will secrete similar amount of insulin. Suppose you are secreting 5 units by eating 1 apple, by 2 apples also, it may be 5.5, but it is not 10. After eating 3 apples, it may be 7, but it is not 15. That's what I am saying. That is the second peculiarity. The third peculiarity is, for which I don't have evidence, that because insulin secretion is a cyclical process, once the pancreas secretes insulin, they get exhausted and they take some time to re-secrete for the second time. And that time is approximately 55 minutes. Now if we read the book, we find that there is the first phase of insulin secretion that happens after 10 minutes, and then the peak occurs at 50, 55, 60 minutes. And then insulin goes down in a period of 3 to 3.5 hours to reach the baseline. So if we use the analogy of a cardiac muscle, you know that if you give a stimulus in the systole, there is no booster effect, no contraction. But when it is early diastole, you will get the booster effect. Similarly for vaccine also, you cannot give 2 doses of vaccine today and tomorrow. You have to have some time, which is 4 weeks roughly. You can use that analogy to the insulin secretion also. Of course, 55 or 60 doesn't matter much once you understand the lifestyle. So this is about the insulin secretion. Next. Now what is the function of insulin? All of us know that insulin is secreted after we eat because it is responsible to utilize the end products of digestion. And medical students, you know that whatever food you eat and whatever quantity you eat, ultimately you are eating carbohydrates, proteins and fats. And you know the end products of each of these, right? So after you eat, in your blood there is glucose, there is fatty acid and there is amino acid. Now insulin is supposed to utilize these end products of digestion. Now you know that there are 2 legitimate fuels. First fuel is glucose. You burn 1 gram of glucose, you get 4 calories. The other fuel is fatty acid. You burn 1 gram of fatty acid, you get 9 calories. So for gram to gram, if you compare, you find that if you burn fatty acid, you get 2.25 times more energy compared to glucose. So if you are a cell, what do you like to burn? Glucose or fatty acid? You like to burn fatty acid. Similarly, all cells of the body are happy burning fatty acids. Exception is the brain cells. They want glucose, they don't like fatty acid. So 70-80% of the blood glucose is utilized by the brain. Now, the first function of insulin is to open the insulin receptor locks on the cells. You know that cells have got insulin receptors. And there will be a lot of glucose in the blood, but unless and until you open the receptor locks, glucose cannot go to the cells. So the first function of insulin is to open the receptor locks and make glucose enter the cells. That is the first function. Now what you eat normally, Indians we eat about 80-85% carbs. Very little protein, very little fat. We eat chapati, roti, shira, idli, all is carbohydrate, mostly carbohydrate. So when you eat, almost there is a flood of glucose in your blood after digestion. So once you send the glucose to the cell, then cells are happy. They use that glucose and their need is fulfilled. But there is more glucose, what to do with that? That extra glucose is converted to glycogen, is stored in your liver and muscles. Now you know in liver there is a limit, adult can store about 100 grams. In muscles it can be 400 grams. The problem with muscle like that glycogen can be used only for that muscle, locally, not for systemic purpose. So it is the liver glycogen that can be used in emergency. If you don't get anything to eat, you are fasting, that glycogen can be taken out and it can give you 400 calories. So these are the two functions of insulin. One, opening receptor locks, making glucose enter the cell. Second, converting extra glucose into glycogen and storing in the liver. Now, very important function comes after this. That once these two functions are over and still there is more glucose in the blood, that extra glucose is converted into fatty acid because of insulin and stored as fats. So you will understand you don't have to eat oil or ghee or butter to become obese. You can do it by eating carbohydrates. Because the glucose that was present in your wheat, rice, jawar is converted to fatty acid because of insulin. So insulin makes you obese. I come to the first point of the principle, that insulin makes you obese. Yes. Now, when human beings came on earth, we were living in jungles. We lived in jungles for 6 lakh years. That's quite a long time. Last 10,000 years we were out of jungle. And out of those 10,000 years, 6,000 years we know agriculture. So when you are in jungle, how are you eating? Like any other animal, you are killing animals and eating. You are not doing anything else. Now to kill animal, you have to run. Not only run, otherwise animal is not going to come to you and say, boss, your breakfast time. You have to run, you have to kill the animal. Not only run, but run faster than that animal. And after killing the animal, you should be lucky enough that a lion or tiger is not following you. Otherwise, you will kill the animal, you have to run away. If that is the situation of your day-to-day eating, can you have the luxury of a bed tea and breakfast and brunch and lunch and supper and high tea? It was difficult to get food. It was difficult to get food. So our physiological cycle was feasting and fasting. Whenever you get food to eat, eat as much as possible. Convert that extra energy into fat. And when you don't get to eat for next 7 days, 10 days, 15 days, guest, to behave like a guest. So somebody comes to Solapur to your place for 4 days. You are happy, you will show us different sites. You will take him to different places. You are happy. But the fellow stays with you for 4 months. Now what happens? At that time you cannot do anything. Atithi Deva Bhava. You cannot drive him away. But next time when he calls and says, I am coming to your house, you say, don't come, I am going somewhere. That is called resistance. That is your resistance to the guest. Now what happens? There is a person, suppose he secretes 5 units of insulin every time he eats. But this fellow goes on eating throughout the day. So he will put 5 units of insulin 15 times in a day. There are many people like that. They go like grazing like cattle. Keep food, they will eat. And they will secrete insulin. And you know that whether they eat 2 biscuits or 1 cup of tea, they are going to secrete the entire unit of insulin that they are supposed to secrete. So what happens? That insulin is always high. And the cells are designed for starvation. They want that it has to go down, but it never goes down. So the cells eagerly wait for Ekadashi. I feel at least this fellow will fast that day. But what the fellow will do? Ekadashi, in Marathi we say Duppat Kashi. I have seen people, they will write on a calendar what are the food items they have to consume that day. Different fasting food items. So the cells say that this fellow is not going to improve. Let us improve ourselves. So what do? The way you behave, if you don't like somebody, some teacher comes to you, what do? You turn your face and go to the other side. You don't face that person. The cells do the same thing. When there is high level of insulin, they change their shape. So the receptor shape changes. And that is the beginning of insulin resistance. So what happens? Because the lock is damaged now, the 5 units of insulin will not be able to work. It cannot open the lock. Message goes to the brain. The cells would send a message to the brain that we are not getting food. And the brain thinks a lot of glucose in the blood. Why they are not getting glucose? So he says maybe our keys now are defective. Insulin is defective. So he says okay, I'll pour some more insulin. So what happens? Instead of 5 units, the fellow will start secreting 10 units every time. That is called as insulin resistance in simple. So with more insulin, glucose will start going to the cells for maybe 3-4 months. Again more locks get damaged. So brain makes it 15 units. Still some more locks get damaged. So ultimately a stage comes when there is a lot of insulin in your blood, a lot of glucose, but the locks are damaged so much so, resistance is so much so that glucose cannot enter the cells. Glucose cannot enter the cells, it passes through the urine. And because there is so much glucose in the blood, body cannot utilize the second legitimate fuel, that is fatty acid. Now what happens? Body cannot use fatty acid or the glucose. It resorts to the third fuel, which it never uses for energy purpose. And that is the amino acids, which are present in proteins, and proteins are present in your muscles. So it will start breaking your muscles, taking energy from amino acids. So you lose weight, there is muscle wasting. Then you go to the physician. Then your morning sugar is 300, post lunch is 400, V.M.G.M.C is 11, 9, 10. And then you are liable to have type 2 diabetes. So what I am saying, that raised level of insulin causes obesity, insulin resistance and type 2 diabetes. There is a myth that once you are diagnosed to have diabetes, 50% of the beta cells are destroyed. This is an assumption without any test. Nobody does fasting insulin in a diabetic. And if you do fasting insulin in a newly diagnosed diabetic, you will find that he has the highest level of insulin in his lifetime when he develops type 2 diabetes. Of course, after 10, 15, 20 years of glimepiride and all other medicines, his beta cells will be destroyed and he becomes type 2. So I have explained you the theory that raised level of insulin causes all the problem. Now if raised level of insulin causes the problem, what is the solution with you? Reduce your insulin level. You failed in exam because you are not studying. What is the solution? Study. In the same way, insulin was more, so you had problem. So reduce the insulin level. Now to reduce insulin level, you know that it is secreted in 2 ways. Can you do anything about the baseline secretion? You cannot do anything about it. So what is in your control is your eating episodes. Insulin secreted because of your eating episodes. So what you will do from tomorrow? Eat less or eat less times? Eat less times. Because eating less or more, you will secrete same amount of insulin. Right? But eating less times is a solution, and then it becomes very easy to understand the lifestyle. Now, the controversy. As I said that physicians and many people feel that you eat small frequent meals, you will secrete small amounts of insulin. That's why they recommend that. On ground, what happens? Have you seen any diabetic patient, the medicines are stopped? You have got relatives with diabetes. Have you found anybody whose medicines are stopped? No. Have you found anybody whose medicines are reduced? Rarely. You will start with metformin, then they will go to glimepiride, then they go to paclitaxel, then they go to insulin. That's how insulin that's at 20 units end with 80 units, 100 units. That's how it is happening. So what is advised is definitely going wrong. No research is required. Now, we conducted an experiment. What I am talking to you is on the basis of research papers published. It's not what I feel. It's not my opinion. It is the evidence that I am talking about. We conducted a study. There are 18 volunteers. We told them that you eat X, 2X and 3X quantities of food on 3 consecutive days. And measure your insulin levels at 0, 10 and 60 minutes. So what should happen if I eat X quantity of food today and 2X tomorrow? I am eating double the calories. Triple the calories the third day. What should happen? The insulin level. No, fasting would be same all the 3 days. Because that is the baseline. But after 10 minutes, if it was 6, suppose, After eating X quantity, then it should become 12. Then it should become 18, third day. Similarly, after 60 minutes, it should happen like that. What was the conclusion of the study? There is no linear relationship between quantity of food consumed and insulin secreted. This got published in a very good journal. So the point that we are saying got proved like this. If you want to say that no, this is wrong, you have to do experiment with at least 19 people. And I have done with 18, you do with 19, then only we can accept. So eating frequency is the determinant of insulin level. Next. So it is very easy to understand a lifestyle. What you said, identify 2 times when you are really hungry, eat at that time. Now very few people understand their real hunger time because they eat before they are hungry. I ask people, why do you eat? And people have different reasons to eat. They say, I eat because I was all alone. They say, I eat because I had too many friends. They forced me to eat. I was bored, so I ate. I was very happy, so I ate. So, why people eat is not because of not hunger, but they eat because of something else. The most important reason for why you eat because you get to eat, no other reason. Now if here the organizers will distribute samosas, hot, how many people won't eat? Everybody will eat. If the neighbor says, I don't want, they'll say, keep it. If you don't eat, I will eat too. That's how it is. Why you ate one? When you are hungry for a samosa, will you go to the organizer and say that I am hungry for a samosa, give me a samosa? No. You ate because it was available. And if it was free, you took two. That's how it is. That's why we eat. So eat twice when you are really hungry. If you don't understand when you are really hungry, then do one experiment. From the morning, don't eat anything. And ask your mother to cook something that you don't like. When you will like that food, that is your hunger time. That is your hunger time. Anyway, if you don't understand, there are 2 patterns which are very common. One is 9 a.m. and 6 p.m. That is one pattern. Other pattern is 12 to 1 and 8 to 9. You can adjust to any of these patterns. Slowly, by trial and error, you come to know what is your hunger time. Finish the meal in 55 minutes. I am not advising you to eat for 55 minutes. There are a lot of misconceptions. People hear what they want to hear. I said finish in 55. Why? Because you should secrete insulin only once. If you go beyond that, you will secrete once. In between 2 meals, don't take anything that causes insulin secretion. And what are those food items? I will be telling you later. Reduce carbs in your diet and increase proteins. But that doesn't mean you have to buy whey, ghee or J protein from market. That's a very fancy nowadays. That you want to buy proteins. You should get everything from your food. You don't require too much of protein. You require hardly 0.8 grams per kilogram body weight. Not much. So if you eat cereals, if you eat pulses, you will get it. You don't have to run behind any company for that. But carbohydrates must be reduced because we eat a lot of carbohydrates. So we have to reduce and increase proteins. Even if you don't have diabetes, eat less quantities of sweets. And sweet I mean sugar, jaggery, honey or sugar substitute. Reduce as much as possible. In Marathi they say साखरेचा खाणार त्याला देव देणार. It is diabetes. Sugar is a poison. Sugar is a poison. So avoid as much as possible. If you are a diabetic, don't take it. But if you are a non-diabetic, then also eat as less as possible. And with this, there is an exercise here. Unfortunately, the Indian population, we are far away from exercise. You go to all jogging tracks in Solapur and count the members. You find that number is less than 1% of the adult population of Solapur. That much people exercise. I asked many girls that when was the last time that you had done this action? Raised your hand above your head. How many times you have done it? Many girls said it was 9th standard. When you do the PT. So if you don't do such simple exercises, you will get a frozen shoulder after some time.
you will have joint problems. So exercise is also required. In the lifestyle, diet plays a role 70%, 80%, 20-30% is exercise. And simple exercise, it's a mass campaign. Walk 4.5 kilometers in 45 minutes. To start with, you may not be able to walk that fast because it is 6 kilometers per hour. But you can take more time, but walk 4.5 kilometers. Because the first 15-20 minutes your glucose will burn, then your fat will burn. So it has to be at a stretch for 45 minutes. You can swim, you can cycle. But if you want to cycle, it should be 12 to 15 kilometers, not 4.5. Now, any exercise, if you want to do Surya Namaskaram, you can do 45 Surya Namaskar, that is also okay. So this is the simple lifestyle. Now, this lifestyle is not recommended for children below 18 years of age. For them, there is a different program that was started, Students Awareness Program for 8th standard to 12th standard. And in them we say that eat 4 times in a day, not twice, 4 times in a day. Second, we say reduce sweets. Third, we say never touch a cold drink. Because 100 ml of cold drink has got 11 grams of sugar. And a child can consume 500 ml in 10 minutes. So actually the child is eating 55 grams of sugar in 10 minutes. It's a junk food. So avoid cold drink. And last important thing is, after this online, stop playing football on the mobile and go to the ground and play for 1 hour. That is the advice given to children. So the first category who should not eat twice is children below 18 years. Second, pregnant and lactating mothers till the baby is 9 months old, they should not follow. And patients of type 1 diabetes. Because they don't actually produce insulin in their body, so they will not be benefited by the lifestyle. So these 3 categories should not follow. Type 2 diabetes should definitely follow. But they have to follow a protocol. Because if they are taking medicine 3 times a day and start eating twice a day, listening to my advice, they will land into hypoglycemia, which is a dangerous thing. They may land into coma, they may die. So they have to follow a protocol. The campaign has got so many coordinators. I don't know whether Atul has come. There is one coordinator, he will come at 6:30. So you can contact the coordinator, they will ask the prescription, they will talk to you and they will guide you properly. For type 2 diabetes, you can definitely revert your diabetes if you are a type 2. What is the problem? Okay, then you go to the next level. Okay. Now whatever I am saying, is there any support? Ayurveda says, Dvau Kala Bunjit. It means eat twice. In Vedas it is written, if you eat twice, you get the punya of fasting. And we do everything for punya. It is the easiest way of getting punya. Eat 2 meals, earn punya every day. In Jainism, there is a concept called Vyasana. What is Vyasana? Vyasana is Bay Asana. Bay means to sit twice, eat twice. And Jain Munis told me they have given 48 minutes for a meal. I said, I have given 7 minutes as grace period. Gautam Buddha told the follower that if you want to be healthy like me, skip dinner, eat only once. Because he was a yogi. Next. In Mahabharata it is written, if you eat once you get health. If you eat twice you get strength. If you eat thrice you get disease. And if you eat 4 times you will definitely die. We say Ramayana and Mahabharata, they are our books, religious books. We read, we don't understand. Next. And this is the advice of saints. It is in all languages, Indian languages. The saints say, if you eat once, you are a yogi. If you eat twice, you are a bhogi like all of us. If you eat thrice, you are a... Everybody knows. You speak like a parrot. You eat thrice, you are a yogi. But till this time, you have consumed at least 7 times food. 3 times tea, 2 times snacks, 1 lunch. So by eating 3 times you become a rogi, by eating multiple times you become a maharogi. That's what is happening. As simple as that. Next. That was about old religion and all that. You say we have people from new era. They'll tell us something new. They study by Dr. Madison, and he is a pioneer of. You must have read about intermittent fasting, Jason Fung, Jamna Das and all that. So he is a pioneer of that concept of intermittent energy restriction. He conducted a study, meal timing, meal frequency and timing in health and disease. And what is the conclusion? Next. He says the most common eating pattern in present society 3 meals plus snacks every day is abnormal from evolutionary perspective. Why is saying that? Because you are a jungle animal. You are not used to eat so many times. That's why he is saying that. Next. 2016 Nobel Prize has gone to a Japanese scientist for a concept called autophagy. What is that? He said if you fast, the normal cells would kill the cancer cells. So what I am telling you, this simple lifestyle which is supported by Ayurveda, Veda, all religions of this country and also by modern medicine, and in heart of heart you know eating so many times is bad. The only thing is you have to realize and implement, then you will start walking to the road of health. Next. What you can eat? People may be interested in this. So if you are a non-diabetic, but who is a non-diabetic? It's not that your blood sugar is normal. You are not a non-diabetic. Non-diabetic has to fulfill three conditions. One is not taking medicine for diabetes. One. Second is HbA1c is below 5.6. Third is fasting insulin below 10. Nobody does HbA1c, nobody does fasting insulin, and they say we are not diabetic. So that's why half of the diabetics don't know they are diabetics. They do it only on blood sugar. So if you are a real non-diabetic in that sense, you can start eating with nuts, fruits, or sweet dish if you are going to eat. Don't eat it at the end, eat at the beginning. Followed by that, a bowl of salad, which means at least one cucumber, one tomato, and whatever raw you can eat. Followed by that, a bowl of sprouts or 2 boiled eggs. The sprout can be raw, it can be cooked, depending on the digestion. And once you finish these 3 food items in the given sequence, you can eat whatever is cooked at home or whatever you get to eat. In a hotel, if you are eating, no problem. This is how you have to eat if you are a non-diabetic. If you are a pre-diabetic or diabetic, who is a pre-diabetic? HbA1c 5.7 to 6.4 or fasting insulin more than 10. Diabetic takes medicine for diabetes or HbA1c 6.5 or more is a diabetic. What they should eat is start with 4 almonds, 4 walnuts or half fistful of groundnuts. Followed by a bowl of salad. You can eat everything except carrot and beet. That increases blood sugar. Followed by that a bowl of sprouts or 2 boiled eggs. And then you can eat whatever is cooked at home. But no sweets, no fruits. No sweets, no fruits for diabetes. Next. In between 2 meals if you are hungry, today you are eating 6 times, 8 times and tomorrow start eating twice, you will have, psychologically also you feel, I am hungry. What you can take if you are a non-diabetic? You can take water, you can take thin homemade buttermilk. Take 2 spoons of curd and make 200 ml of buttermilk. You can take plain green tea, black tea or black coffee without any flavor. Coffee without chicory, it should be pure. You can take tea or coffee with 25% milk. Don't add sugar, jaggery, honey or sugar substitute to that. You can take 1 tender coconut water in a day, not every hour, once in a day. And you can take 1 tomato in a day. This is what is allowed for it. Why this is allowed? Because I have done experiments on you should take, ideally, the first is water, second is water and third is water. The best is water. But you can take water, you can take thin homemade buttermilk, or you can take plain green tea, black tea or black coffee. No sugar, jaggery, honey or sugar substitute. So the other 3 food items, tea, coffee with 25% milk, tender coconut water and tomato are not allowed for pre-diabetic and diabetic. That is the difference between the 2 lifestyles. Next. There are so many lifestyles. I tell you eat only twice. There are people who tell eat every 2 hours. And people have modified it. They eat 55 minutes every 2 hours. Then combination also people have. And they say our lifestyle is good. Everybody says. I won't say that. What I will say, there are 4 objective improvements you will see if you follow what I am saying. There are 4 objective improvements. One, your weight will go down. You will reduce your weight. How much? On an average 6.8 kg in 6 months. On an average. And whatever I am saying is on the basis of research papers. This is the only lifestyle where you lose your tummy first. The chicks would never retract. You do anything else, gymming, protein powder, plus your cheeks retract. People start asking questions, whether Dean had changed. Or any problem at home. But here nobody will ask the question because you lose your tummy. How much? 1.5 inches in 6 months. Range 1 to 4 inches. Life becomes beautiful. If you are triple XL, you go to the shop, you want to buy a dress. The shopkeeper gives you three pieces. He says, Madam, select. I got only 3. But if you are L, there are 200 designs. And you can choose. Life becomes beautiful. So you lose weight, you lose your tummy. Third thing, your HbA1c will reduce. Now you say that my HbA1c is 5.5. I am not diabetic. Good. But after 3 months, it becomes 5.1. Still better. And your fasting insulin goes down. Fasting insulin is a proxy indicator of insulin resistance and impending type 2 diabetes. So if you are at 12, if it becomes 8, you have improved yourself. So the 4 objective improvements will happen. Next. Now what we learned from the campaign? The campaign started in 2013. Last 10 years I am working in this. Myself and my 100 coordinators, we work for this cause. This is a campaign which is absolutely free of cost. No money is taken from any patient. What we learned? We learned that diabetes is underdiagnosed in the country. Because half of the people don't know they have diabetes. We diagnose them by blood sugar. And the Indian mentality is to be afraid to get diagnosed. We are not afraid of a disease. So if I tell you to do blood sugar tomorrow, today you will eat less. You will not eat any sweet. Even you will run for 10 kilometers. So tomorrow your blood sugar is normal. So you are missed in diagnosis. So whatever studies we have done, we find that 20-25% people don't know their diabetes. So it is underdiagnosed and it is overtreated. Why I am saying that? All guidelines tell you to suggest lifestyle. First thing is lifestyle. We conducted a study which was published in the Indian Journal of Endocrinology and Metabolism, which is a PubMed Index journal, 3,200 patient study. In half of the patients, they started medicine the same day when they were diagnosed to have diabetes. Well, it is a question of lifestyle. So why lifestyle is not suggested? Because physicians don't trust on the lifestyle that they suggest. And the patients know the lifestyle doesn't work. Because they are saying everywhere, once you are a diabetic, you are a lifetime diabetes. So people write books, make friendship with diabetes. Anyway, it is not going from your life. You have to be friends. The lifestyle doesn't work because if you eat small frequent meals, it is a definite remedy to become a diabetic from pre-diabetic. 200%. And you can do experiment on this. We have done experiments. So lifestyle was suggested, so it is over-treated with medicines. Now another thing, whether it is the blood sugar about which we are worried in diabetes, no. We are worried about the end organ damage. The diabetes will cause complication in kidney, heart, liver, retina. We are worried about that. If somebody has HbA1c of 10 today, does it mean it has happened overnight? He was having high blood sugar for the last 1 year, maybe 2 years also. So, if you find out, if you do investigations to find out end organ damage, like serum creatinine, eGFR, urine microalbumin, retinoscopy, and all that, and if the person is alright, you can suggest him lifestyle without giving medicine. And we are doing it at our centers. So, because there is no convincing evidence to say that if your blood sugar is 300 for 6 months, your retina will get damaged. Or if blood sugar is 450 for 2 months, your kidneys would get damaged. There is no evidence like that. So we have to go for end organ damage. If it is there, things are different. If it is not there, you can suggest lifestyle. Next. Delayed drug initiation is the best reversal. Why? Because you follow lifestyle and you take medicine, you have more chance of getting hypoglycemia. So, in the reversal process, we have to be very careful. But if you are not starting on medicine, I have seen people with HbA1c 14, 15, 16, reverting their diabetes, HbA1c going below 6 in 5 to 6 months. I can show you many cases like that. Because they are not taking a medicine, it becomes easy to revert. One more thing. I don't know why people don't accept this. They practice it actually. Hypoglycemia is an opportunity to reduce the dose of diabetes medicine. Now what happens? I take medicine at 12. I get hypoglycemia at 4. I will call my doctor. I am having this unpleasant feeling, right? So doctor will say you have to eat something sweet or something to increase your blood sugar. That is normal. That is to be advised. Otherwise you will land into complications. Tomorrow what happens? I am waiting for hypoglycemia. I have that experience at 4. But tomorrow from 3:30 onwards, psychologically I am disturbed. I will get it. I will get it. So at 3:45 I will eat something. So that I will not get it. What happens then? I will go on eating like that every day at 3:45. When I go to the doctor, my HbA1c is increased by 1 point. Doctor gives me one more medicine. Again I get hypoglycemia. I will eat more. This vicious cycle continues. Now what our doctors do at our diabetes reversal centers, if you get hypo at 4, we reduce your glimepiride from 1 to 0.5 at lunch. So for some days you won't get hypoglycemia. You will get hypoglycemia afterward. Getting hypoglycemia is a good news. Because that means your dose is to be reduced now. And that's how diabetes get reverted. Patient medicines are stopped. One more thing. If you lose 10% weight, your diabetes will be reverted. Very easy to say. I have seen hundreds of cases where the weight loss is not even 2%, 1%. The HbA1c has gone down from 10 to 5. If you are overweight, definitely. If you lose weight, it helps. Even if you are not overweight, you will reduce your HbA1c by just reducing your eating frequency. So this is the learning from that. Next. Example of V.M.G.M.C. HbA1c 15.6, average blood sugar 383. He lost 25 kg weight and HbA1c reduced to 5.4 in 7 months. Till date, V.M.G.M.C doesn't take any medicine for diabetes. There are hundreds of such examples. If you visit our website www.adortrust.org, you will get those stories. Every day on our WhatsApp group we publish at least one success story since 2013. So there are thousands of stories. Next. This paper got published in Indian Journal of Community Medicine, which was a trial where one arm was given this lifestyle, other arm was given the conventional lifestyle. We found that after 240 days of follow, this lifestyle, there was a reduction of 1 gram per cent. The reduction in the dose of medicine, reduction in the molecules given. And all those doctors which are in red letters, they are all MD medicine doctors. This study was conducted at Nasik, Kalyan, Aurangabad, different places. There are physicians who support us in this campaign. Next. Next. This was another study that was published. Next. Next. Now we are going to conduct a study because raised level of insulin causes PCOD, infertility, and then they have to go to IVF center later. So we are conducting a study with Dr. Gupta. I think most of you must be knowing him, very famous gynecologist from Pune. And we are going to study the change in microbiota by following this lifestyle. And the study is going to start on 1st of July. Next. This campaign has reached 41 countries with millions of followers. We run 14 diabetes reversal centers. One at Surat, one at Madgaon, one at Belgaum, and 11 centers in Maharashtra. We run one center at Solapur also, at the Masonic Hall, every 2nd and 4th Wednesday. The center runs. And Dr. Damangaonkar, who is MD Medicine, she helps us in this. There is a Dr. Dikshit Diet YouTube channel. I think first thing you should do is, once you go home, find out Dr. Dikshit Diet YouTube channel. There are more than 200 videos and there are more than 50,000 subscribers. So watch those videos, subscribe, share, so that it goes to masses. Recently, Infosys Foundation has given us help under the CSR to start 2 centers, one at Pune, one at Nagpur. And CTR company has given CSR to start center at Nasik. This is a project of 3 years where we want to revert diabetes in 1,000 patients at each center. All the diabetes remission trials in the world are of 100, 200 people. And we are talking about thousands. And surely this will get published in good journals after 3 years. And I think that it will be accepted by everybody that this is the first line of treatment for all type 2 diabetes. Next. December 2019, I was invited by Modi ji to deliver lectures for Prime Minister Office staff which included from his driver to his chief scientific advisor. 600 people who attended the lectures. Special protection group and their families. I gave a lecture to Member of Parliament in the Parliament, the Bal Yogi Auditorium. And then I met Modi ji. He talked with me almost 15 minutes, you can understand. Prime Minister of the country talking to a professor doctor for 15 minutes. He understood what is the lifestyle and we discussed so many things. And then the news came in after 5-6 months in Dainik Bhaskar. And journalists asked for diet plan. And the heading says, मोदी जी का डाइट प्लान दिन में 2 बार भोजन हर बार 55 मिनट में पूरा करते हैं खाना. So the Prime Minister of the country also follows this lifestyle. So if somebody tells you that somebody follows, you say don't worry, the Prime Minister also follows. Next. What do I expect from you? You are all medical students, you are doctors. The first thing very important, don't trust me. I have not trusted Dr. Jiska. I trusted on my own experience. And to get experience, you have to experiment. The problem with intellectuals is we think so much, but don't do anything. And you will never revert your diabetes or lose weight by thinking. You have to do something. Give 3 months of your 100 years of life to me. Your 100 years of life, give me 3 months. Measure all the 4 parameters tomorrow. Follow for 3 months. Again measure after 3 months. If everything happens the way I have said it, trust your own experience and make it a lifestyle. Tell everybody about this. Guide everybody. Join the campaign. Because this campaign is not only of Dr. Dixit or 100 coordinators. It was never of only Dr. Jiska. This is campaign of everybody, all of us. There are so many books that I have written on this topic, and these books are there. I got those books for you. If you want to buy, you can buy. That money goes to the trust. So it will indirectly help the trust. Next. Okay, you can take the photograph of this. If you want to help your relative who is having diabetes, you can send message to either Dr. Manisha or Dr. Nandakumar. They are my doctor coordinators. They will help your patients. You can watch YouTube channel, you can visit our website. And more than donations, more than money, what is important is a doctor becoming a role model. A doctor becoming a role model. Dr. Saifi Arsiwala from Kota, who is a cardiothoracic surgeon. Dr. Kubal from Thane, who is a cardiothoracic surgeon. They are our role models. They follow this lifestyle and openly tell that yes, we follow. Dr. Nitin Gaisas, who is a physician from Nashik, he says that yes, this is the lifestyle, everybody should follow. This is the only answer to pandemic of diabetes in the country and the world. Now, so first thing, you try it yourself. Get the benefit. Then start telling others. Join the campaign. Make it a lifestyle. Why I am telling this all to you? In this country, there are 10 crore diabetes. 50% of the amputations that happen in the country, they are on diabetes. 50% people losing their vision is because of diabetes. If you even take a medicine like metformin twice a day, you spend 300 rupees every month. And 70% of the people, the families of India don't have income 5,000 rupees a month. Imagine in a middle class family, if a man of 55 years, his leg is amputated and he will survive for the next 30 years, what will happen to that family? That family will go below poverty line, for sure. Because treating complication is impossible for a country like USA or UK. India cannot do that. In that background, there is a person who is telling you a lifestyle that is free, that doesn't require a doctor expert, doesn't require a machine, doesn't require a powder to be bought, and more importantly, you can happily follow it for lifetime. Then I feel, as a responsible citizen of this country, it is our duty to give it a try. I am not saying trust, I am saying give it a try. If it helps, you must tell it to others. That's what is the aim of this lecture. So thank you very much for your presentation. These are the references. Next. These are research papers that I have published. Thank you very much.
Anyone among the audience, if anyone has any questions, you can please ask the sir.
We thank Dr. Dixit for enlightening us. I think that Dean Ornish had his reversal of cardiovascular disease and many people have helped from that. So I am also a follower of this diet. I follow it for the past 2 years. And I have experienced the improvement. The Dean Ornish had said that if you are not able to completely follow this, even if you follow by part, you will get part benefit. Does Dixit's plan also follow that, or he insists that it should be followed totally? And another question is that there are a lot of things about the soleus exercise. So does he have any opinion about it? Thank you.
So definitely, if you follow 50%, you will get 50% result. That is sure. But I insist people to get 100% results. Why to settle on 50%? And about the soleus, if you read the article, somebody sent me some 17-18 pages article. It says if you do it for 210 minutes, 4.5 hours, you will get the result. Now, any exercise for that matter is going to reduce your blood glucose. But do you recommend people to exercise after they eat food? Generally not. Why? Because the blood supply is supposed to go to the digestive system, not to the muscles. If you do the other way around, your digestion will be at a problem. And if somebody has to do exercise for 4 hours, it's okay. He will reduce your blood sugar. It's not a very effective way of reducing your blood sugar. The other exercise that you can do that are better, but do it on empty stomach, not on stomach. Any other question? Yes.
Good evening. I am from V.M.G.M.C Institute of Technology. As a non-medical student, I just wanted to ask, what are the early symptoms of diabetes?
Okay. So the traditional symptoms we say that you feel more thirsty, you are more hungry, you go to urination more times. These are the 3 things that happen, and you lose weight. Despite eating more, you lose weight. This is what is the classical symptoms. And itching sometimes, infections, repeated infections, all that you get. Blackening of your skin at some places. These are such sort of things. But unfortunately, what happens is 50% patients don't have this. That's why they go undiagnosed. That's why we call it a silent killer. Some people get it, some people don't get it. But these are the classical symptoms. Thank you.
Sir, will it worsen the acid peptic disease eating 2 times in the morning and evening?
Okay. So what happens is hyperacidity. The main cause of hyperacidity is not eating when you are hungry. This happens in females many times because they have to look after the household chores. They do a lot of activities. They are hungry at 10. But because they have to give tiffin to the child, tiffin to husband, do a lot of work, and then eat at 1. Hungry at 10, eat at 1. What do? Go on drinking tea one after the other. So they get acidity. Now if it is a structural problem, definitely you should not do that. But if it is hyperacidity, as we commonly say, then if you eat twice when you are really hungry, 80% problem will be solved. In this campaign, 30% of the success stories are the people who say our acidity has gone. First 8-15 days you may have to take a medicine for that, an anti-acidity that you are taking. But slowly, in a month or so, this problem will vanish.
So regarding calorie restriction, you gave the list of food items. So is there any calorie restriction in it? And sir, second question regarding this empty stomach, you consume lemon water with honey and all that. Can that be added to this or no?
Okay. So people do so many things to lose weight, and this is a very popular thing. In warm water, put some lemon, honey, and methi dana and all that. Fenugreek. So what happens if you do that on empty stomach? You are having a meal for us. If you are a non-diabetic, you can take that honey, no problem. But start your meal 55 minutes time with that water. You are empty stomach anyway. You can take it. Of course, that has no effect. People drink this water and honey for years together. What happens is only they help the person who sells honey. Nothing happens to their bodies. That is true. So fenugreek and all that, whatever you want to take, you can take as a beginning of your meal. Wait for 15-20 minutes and eat other food. No problem. And there are another question.
Calorie restriction.
Calorie restriction. Okay, that's a very popular thing. You go on internet and you say, I want to lose weight. They say, how much weight you want to lose? 1 pound per week, 2 pounds per week. Then accordingly they will cut your calories. And the direct trial of UK, what it says, you can remove diabetes. You have to eat 840 calories. Now, who will eat 840 calories? One can eat as a clinical trial subject for 2 months, 3 months. But later on, I want to eat. So, it is given in park also. That if your calories are reduced by 7,000 calories, you lose 1 kg. If life was that simple, everybody would have lost weight. It doesn't happen. It happens in poultry. In chicken, you feed particular amount, then their weight gain will be there. That doesn't happen in human being. You find 2 friends, they eat the same maize. One is thin, he will eat 6 chapatis. One is obese, he eats only 2 chapatis. But he puts on weight. You have seen that. Because there are genetic factors, there is a basal metabolic rate, so many factors that operate. It's not that easy. Calories in, calories out. It is put very easily, but it's not that. It doesn't work. And if you want to follow any lifestyle, unless it is sustainable, you will not have sustainable results. You can eat only 1 chapati morning, evening for 3 months, 2 months. But later on, you will have craving, you will eat more. Whatever 4 kg you lost, you will put on 6 kg next thing. So calories is not that important. Frequency is important. It causes some 10% reduction in calories as per our estimate. If you eat twice instead of 3, 4, 5 times, it will definitely reduce calories, but not much. Not like 840 calories. It is about 10% you will decrease.
You gave the list of food items and then you said you can eat anything after.
Yes.
So that's why
That's the easy way of saying people, don't eat much. Because this is a mass campaign. We don't speak about glycemic load, glycemic index and all that. If you eat nuts, salads, sprouts, whatever you eat, your glycemic index has to go down. The glycemic load has to go down. And you can eat full stomach, no problem. That is also the advantage. You can eat. You want to eat a pizza, you can eat. After these 3 food items. So no craving for these foods. Anything else? Any other question? So I wish all the boys and girls sitting here look the same way after 20 years. And thank you very much.
Thank you so much, sir. That was really inspiring and a very thought-provoking session. Sir took a deep dive into the diabetes mellitus, and he explained all the concepts to us. Now, I would like sir to be felicitated by our Deputy Dean and the Head of Department of Surgery, Dr. Ritvik Jaikar, sir, and the UG Deputy Dean and Head of Department of Pathology, Dr. Sunita Dantakaya ma'am, and the Head of Department of Community Medicine, Dr. Santosh Namaskaram, sir. Now I would like to call upon Dr. Katikar sir and Dr. Chidgurkar ma'am to join Jaikar sir so that we could have a group photo.